Welcome. Thank you very much for signing on to Get a Grip on Chronic Pain. Today we're going to be looking at fibromyalgia and myofascial pain syndrome specifically as components of complex chronic pain patterns that you may meet in your practice. Welcome. My name is Teresa Schmidt, and it's a pleasure to share this information with you today and hopefully to help make your practice a greater success. If you're doing this program as a home study or in a group study, just a couple little directions for you. This is basically an audio-visual program made from PowerPoint slides. So just follow through the program. Feel free, because it is a video version, to pause and stop at any time. You can always resume the program if you wish. Thank you very much for participating. If you're looking at getting continuing education credits for the program, Exercise Resources Incorporated is approved by many boards for giving continuing education credit hours. You can check with your state board if it's approved in your region, or simply contact us at educise.com to find out if credits have been approved for you. If the credits have been approved, you would be required to take a simple multiple choice exam upon completing the program. Typically, there are about 25 questions, and you would submit those through our website, educise.com. The program would be graded for you. You complete a course evaluation and submit both the exam and evaluation, and your certificate will be sent to you if you have a passing grade of 70 or better. If for some reason you did not pass with a 70 or better, no problem. You can retake the exam again. So feel free to visit www.educise.com for more details. There are many particular tools expressed on this program. If you go to some of the websites listed in the references, and also on this slide here, you'll be able to see references. Rehab Measures is a great place to find functional outcome tools, because you want to document that you made a difference. And there are plenty of places to access free tools for easy documentation right at your computer. So rehabmeasures.org is great. Orthopedicscore.com is also fabulous. And there's a long-winded one here, Registry of Outcome Measures with minimal detectable change, in the very long address at the bottom of the page. So since these are copyrighted functional outcome tools, we can't give them to you in the program, but they are free and easy for you to download. So as we reference those, feel free to get your own copy. I'm Teresa Schmidt, and it's a pleasure to share with you. I have 30 years of experience, and I've treated many patients with chronic pain. As a matter of fact, I tend to be a magnet for people with chronic pain coming into my office, because there's very few people who enjoy treating this problem. People with chronic pain tend to have multiple diagnoses, tend to have complex situations, overall many different conditions across multiple areas: orthopedic, cardiopulmonary, integumentary, okay, all different levels. So you need to be able to check multiple systems on your exam. I have been doing this for 30 years, and I found that the hands-on therapies are most efficacious in treating people with chronic pain, in combination with multifactorial programs and programs that include multidisciplinary approaches, both complementary and allopathic. I'm a physical therapist. I'm board certified in orthopedic physical therapy, and I'm also a licensed massage therapist in the state of New York. And I like to use the various modalities available to me, both in PT and massage, to address issues of chronic pain, particularly neuromusculoskeletal system. If you have any questions after the seminar, feel free to contact me. You have my website, which also lists my phone number, toll-free number if you have questions, or simply send an email through educise.com, and I'll be happy to respond to you. Any resources you may need, a patient question, or maybe just a comment about the program in general. So we're ready to get started. You might want to have a piece of paper ready, because I'll ask you to maybe take a note or two as we go through the program. If you're looking for additional information, you'll find some resources in a reference list at the end of this program where you can get extra information, usually free and online. So got that paper ready? Okay. How do you feel about treating people with chronic pain? They come into your office, maybe your schedule only allows you to see a certain number of people an hour. Maybe you're overloaded with patients at a time and you're thinking, wow, this is really time consuming. So how do you feel about treating chronic pain? Let's write a few things down. Reflect for a moment on, say, 2 or 3 patients you've seen who had chronic pain, who presented a challenge to you. How do you feel about that? What did you do? How successful were you in managing their chronic pain? Wondering about that, write it down. So write down the names of 3 people, use a fake name for HIPAA purposes, write down what their primary issues were, and take a look. What interventions did you find most successful in managing their problem? What worked? What didn't work? That's a big one too. So you want to say we're going to be ruling out a few things right away. Okay, what was your success rate overall with people with chronic pain? Make a note of it. What's your favorite intervention to use in managing chronic pain? Now thinking about that situation, is there something that you'd like to change in your approach? Is there something you felt you could do just even a little bit better to help these kind people? Okay, write that down. At the end of this program, you might want to revisit, reflect again on how you might change your approach after considering what we cover here in our chronic pain program. Got pain? Yeah, how many people have chronic pain either from post-surgical problems, multiple traumas? How about fibromyalgia? Who can't wait to see that fibromyalgia client again, right? No, not many out there. I often ask that question in my classes as I travel around the country, and I might be talking to 100 people. And 1 or 2 people might raise their hand, oh yeah, we'd like to see them again. But typically people aren't too interested because this is a major challenge. And with the managed care system, or what I'd like to call the mismanaged care system, it makes it even more of a challenge. How about chronic fatigue? Can we even figure out why people are always tired? They don't want to do your stinking exercises. They're not interested in that home program you gave them. What is it about what we're using for our average patients that tends to fail when we're addressing people with chronic pain, especially chronic fatigue? How about those digestive disorders they complain about? Do you feel adept at treating those? What about that continuous musculoskeletal pain? Say someone had a trauma or a surgery, never quite got back on their feet, or never quite got rid of that pain. It's just part of their everyday life. It's affecting the quality of their life. What can we do about it? So who addresses chronic pain? Typically people taking this program are health professionals, allied health, medical professionals, and what they're saying now is the primary care provider is our first resource. Someone goes into their main physician, who may end up being a nurse practitioner, physician's assistant, might be the gatekeeper, and they're complaining about what their problems are. How many minutes does your primary spend with you when you go for a visit? Oh, 5, maybe 10? Do you think they have time to hear all the complaints that you could come up with? How about that patient who has chronic pain with a dozen different complaints? How much time will they have to focus there? So eventually patients get referred. Rehab professionals, physical, occupational therapists, massage therapists, psychotherapists. His pain is not just physical. Pain is emotional. Pain is mental as well. So there's many layers to the pain problem, and it needs to be addressed by multidisciplinary approaches. How about social workers? Complementary medicine, acupuncture. What about athletic trainers, chiropractors, nutritionists, dietitians? Have you ever thought of referring your patients with chronic pain to look at their nutritional status? Now, as a physical therapist, I'm not licensed to give nutritional advice or talk about vitamins or supplements in my state, but I can certainly refer to someone who is. And I make sure I look at that because typically the standard medical approach is not looking at what people are eating day to day. They're not looking at the nutrition. You ever hear that phrase, you are what you eat? Well, if what you're eating is a bunch of junk, you might have a bunch of junk inside, contributing to the chronic pain. And we'll take a look at some of those factors as well today. Now, some relevant diagnoses: myofascial pain syndrome and fibromyalgia. These are the big 2 we're covering in today's program. Many times these are confused with chronic fatigue syndrome or Epstein-Barr virus, which is pretty much considered synonymous in the diagnostic world. How about gastrointestinal problems like irritable bowel? People complain about alternating diarrhea, constipation, reflux. Oh yeah, I'm on that purple pill. So you hear a lot of these in combination with chronic pain problems. We're going to look very closely at doing a differential diagnosis of fibromyalgia and myofascial pain, which often contains some of those other diagnosis criteria as well. What other conditions are present with chronic pain? Well, one of the latest things you'll see in the current research is HPA axis hypersensitization, or HPA axis sensitization. Here's a mouthful: hypothalamic-pituitary Adrenal Axis sensitization. What is that? These are your master glands in your brain, right? And of course, adrenals above your kidneys. This is what's controlling some of what we call our fight or flight response. It's controlling our neurotransmitters, the chemical messages that bring messages throughout the body. So it's very, very important to take a look at the brain and nervous system response as well as the neurotransmitter and hormonal response to pain. There's a complete change in the brain's perception, its processing, as a result of people enduring chronic pain. We'll take a look at some of that. So yes, the mind and the body are indeed connected. We can't separate them. I know very often your practice acts want you to separate. Well, send the person with the emotional problem to the psychotherapist and send them with the physical problem to the PT or the OT, or all their muscles are just tight, send them for a massage. It's not enough. We need to put the whole system together and view people as a complete unit, not as little individual body parts that you separate and send to all different places. So we need to put people together as a whole. That's what holistic approach is all about. How about post-traumatic stress disorder? How many people do you see coming in who've had some type of trauma? How about 9/11? It's a perfect example. I was downtown Manhattan on 9/11. How many people did we see after that with all kinds of vague symptoms, sympathetic overload, pain problems, fear avoidance behaviors? What about people who are coming back from war, some of our veterans? What's being done for that PTSD? So it's not just a physical issue, it's also a behavioral issue, and it affects people on multiple levels. Gulf War syndrome, perfect example. Interesting that just a few years ago, the Veterans Administration declassified Gulf War syndrome basically as post-traumatic stress disorder fibromyalgia. Same symptoms, same presentation. Okay, so let's take a look at dissecting out some of the various symptoms of the clinical presentation for chronic pain. So two main types to look at today: fibromyalgia, which is called FMS, and myofascial pain syndrome, MPS. So who can't wait to see that patient with the chronic pain again, right? Send them over here. I love it. When you start to change your approach and include a more multifactorial approach to management of chronic pain, you'll look forward to seeing them as well, because we do get good results. Now take a look at fibromyalgia. How many of you have seen folks with fibromyalgia? How many of you have seen people who were diagnosed with fibromyalgia but had another condition? I've had a number of patients referred to me who actually had cancer, multiple myeloma, or other forms of cancer, who were diagnosed with fibromyalgia. Doctors couldn't figure out why they had pain, why they were waking up at night. Oh, you're stressed, you must have fibromyalgia. Now, unfortunately, they didn't do a very good differential diagnosis, and those very patients I'm thinking about right now actually have passed away because they were not properly diagnosed. This needs to be taken care of. So if people are not getting a good response from the medical practitioner they're seeing, if they're not getting a clear diagnosis, you need to make sure and refer them again to another specialist. They should have an appropriate diagnosis and an appropriate medical workup. Let's look at the people who used to be considered the experts in treating fibromyalgia. Interesting. American College of Rheumatology, or the ACR. Now, they changed all of their criteria that have been developed for diagnosing fibromyalgia back in 2010. So if you're looking at some of the older research, you're going to see different diagnostic criteria than today. And back in the old days, 2010 and before, the rheumatologists were considered the experts in treating fibromyalgia. That's where these people went. They thought it was basically a rheumatic type of condition, although they couldn't figure out of what type. Well, rheumatologists have decided we don't want to treat this anymore, so we're sending them off to the primary care provider. What a great way to unload your patients with chronic pain that take up a lot of time. Let's just send them off to somebody else. But that's what's happening. So American College of Rheumatology 2010 criteria is now the new criteria used in the US for clinical diagnosis and severity classification. And the diagnosis is based on a few features that are very different than what's been done in the past. There's a functional outcome measure called a widespread pain index, or WPI. And again, you can download some of these free online, and I've given you those resources. If they have a WPI greater than or equal to 7, score of 7, and a symptom severity scale, yet another scale, greater than or equal to 5, or a WPI from 3 to 6, and a symptom severity score of greater than or equal to 9, they're considered to have fibromyalgia. So you need to do a little bit of functional outcome tools, measurement, get a score, and see where they fall within that realm. They need to have had these symptoms for at least 3 months. That's classic for chronic pain. And they need to be without any other diagnosis that they feel would completely explain the pain. So typically, people who come in with fibromyalgia, it's not just fibromyalgia. There's not a blood test that you could just run and say, oh, you've got fibromyalgia. It's actually a constellation of clinical symptoms that patients present with, and they're just grouped together. So typically, it's occurring with other rheumatic type conditions such as rheumatoid arthritis, lupus, or ankylosing spondylitis. Not always, but a very high combination that we see in the literature. And as far as ICD-9 codes, now I know as of 2013 we were supposed to be switching to the ICD-10 coding for diagnostic classification. That's been moved forward to 2014, but still we don't have a specific diagnosis that's just known as fibromyalgia. Typically, according to the coding rules for diagnosis codes, fibromyalgia is coded along with myositis and myalgia, which is code 729.1. Might this change with ICD-10? Could be, but we don't know yet. Still a surprise. So the important issue here is myositis and myalgia unspecified, because they're really not too clear. They know that it's hurting in the connective tissue, but they're really not sure where. It can affect multiple systems. It may also include other conditions. So more criteria. This is a quote from American College of Rheumatology. Fibromyalgia is a disorder of unknown etiology characterized by widespread pain. That's the classic diagnosis. Abnormal pain processing. That's new. Is it not considering the body as just a somatic pain process? They're actually considering it affecting now the brain. So pain processing by the central nervous system. Also, classic criteria, sleep disturbance. These people are not getting a good night's sleep. Either they're waking up or they have a disturbance of their sleep rhythms. They're tired. It's one of the key elements they'll present to you as a complaint. I'm too tired to exercise. I can't seem to manage getting things done around the house. I go to my job within, 15, 20 minutes of trying to do my work. I'm exhausted. So fatigue is a very large component. And they often complain of some type of stress, some type of psychological distress. Oh, I'm under a lot of stress, I'm going through a divorce. Or, oh, my kid got an F in all his classes, I don't know what to do. So there's always some other component, typically psychological or emotional, that they can also share with you. The key is, did you take the time to listen? Did you give them the time to present to them your complaints? So in addition, they'll complain about, I wake up in the morning, I'm all stiff, my joints are cracking, it's hard to get going in the morning. Oh, my hands and feet are tingling, my hands are numb, they feel swollen, feet are swollen. If you examine them, you could do nerve conduction velocity tests, you could do EMGs, you could do all kinds of tests to measure circulation, and you find that it's perfectly normal on standard medical tests. You don't find numbness, but yet they feel it. So they've often been told, oh, that's all in your head. We stuck you with the pin, you jumped a mile high. Yes, you're not numb. Oh, we don't notice any swelling. So everyone thinks that it's all in their heads. Well, guess what? A nice component of fibromyalgia is in the mind, because mind and body connected. Last time I looked at my patients, the heads were still attached. Let's stop disconnecting people's heads and look at a whole person and look at their whole situation. And frequently they have headaches. including migraines. So it could be tension headaches, migraine headaches, very, very common with fibromyalgia. What else are they presenting with? Well, they're not digesting their food. So that irritable bowel syndrome, IBS, is something they typically are diagnosed by their GI doctor, gastrointestinal doctor, and that's them saying, I feel bloated, I feel gassy. One day they have diarrhea, another day they're constipated, so they're never quite comfortable in the bathroom area. And it's very, very hard to treat the irritable bowel syndrome. Comes and goes, not terribly predictable, and how comfortable do you feel in treating this, right? Well, they're not getting too much results in going to the GI doctor either, so that's something to think about. Sleep disturbances, we mentioned. Some people will say, yeah, I slept through the night, but it was a fitful sleep, or I wake up all the time. A lot of the patients I've seen, thousands of people with fibromyalgia over the years, nightmares, or just, I don't feel rested when I wake up. What's going on? Then they have what's called fibro fog, brain fog. They feel confused. Well, hey, if you don't get a good night's sleep, how clear is your thinking the next day? So that's also a newer, more common complaint, is actually called fibro fog. So other pain syndromes, hormonal disturbances, particularly in females, dysmenorrhea is a common component of this. So a lot of systems are out of balance. Let's take a look at the prevalence of fibromyalgia. Now, this has been looked at very differently even within the last couple of years. So it's 2014 now, and they've looked at the prevalence of fibromyalgia. They used to say it was really a female disease. It's much more prevalent in women. Well, the newer statistics show there's actually an equal prevalence between males and females. It used to be higher in women, 3.4% versus men, 0.5%. So look at the most current statistics. Remember, back in the old days, it was considered a woman's disease. Because let's see, why is fibromyalgia a woman's disease? They couldn't find anything wrong with them, and they're always hysterical about something. And where does the word hysterical come from? Well, let's see. Hyster means uterus. Only women have uterus, so only women are hysterical and emotional and can't control themselves. And therefore, let's say it's a woman's disease, fibromyalgia. Back in the old days, they just called it hysteria. That was an actual diagnosis. I know, it's absolutely ridiculous. But now that the diagnostic criteria are more clear, we're finding that it's actually equal prevalence between males and females. It's not considered non-macho to diagnose a guy with fibromyalgia. So take a look. They did a newer study in Minnesota, which is very well recognized. This is fairly recent, 2013, and they're showing that depending on how they applied the statistical package to the data, it's between 1.1% and 6.4% of prevalence, and equal men to women. Also includes children, something to think about. I never, ever used to hear about fibromyalgia in children years ago when I was a therapist. But in the last, say, 10 years or so, I'm seeing much more diagnosis of fibromyalgia in children. It's getting kind of scary. But they're diagnosing differently, and that's what you need to look at. It's not that the disease necessarily changed, but the diagnostic criteria have changed radically. And if you look at those criteria in Europe versus America versus Canada, completely different. So maybe at some point the World Health Organization will come up with a better definition for fibromyalgia. Most of them are using the ACR criteria that we're looking at here. So it's been very underdiagnosed in the past because it didn't have clear classifications. Mayo Clinic did a study on fibromyalgia and chronic fatigue, CFS, chronic fatigue syndrome. Mayo Clinic, of course, very well respected. Prevalence 4.88% in men, 7% in women. No statistically significant difference between the two. And now we're seeing more and more prevalence in younger age groups as people are better diagnosed. So what does this cost? Well, they say between 1979 and 1998, there was about 23 deaths per year attributed to fibromyalgia. Now, I'll tell you, I've never heard of anyone passing away because of fibromyalgia, but I think that the combination of other things going on, other comorbidities, could possibly have been playing a part. So crude number of deaths coded as underlying cause of death as 729.1. Remember, that code is myalgia, not necessarily fibromyalgia. But it's gone from 8 in 1979 to a high of 45 in 1997. So this myositis myalgia, 1998, only accounted for 0.5% of all deaths attributed to arthritis. So it's not typically something someone's going to be worried about dying from. So what's the issue is the mortality among adults with FMS is similar to the general population, but we're finding higher death rates due to suicide, okay, and injuries for people who have fibromyalgia. So again, you need to take into consideration the emotional component, and I am certain to refer these people for, proper health care management from a psychological and emotional perspective. How about hospitalizations for myalgia? As a principal diagnosis, over 7,000 hospitalizations, and typically people with FMS typically have about a hospitalization every 3 years. What does it cost? About $3,500 a year per person to have management for fibromyalgia. That's just medical costs. If you include indirect costs, you're talking about $6,000 a year. How many of these people not only go for standard medical treatment, which may or may not be covered by insurance, but they're reaching out more into the complementary medicine realm. They're paying for massages. They're paying for all kinds of nutraceuticals. They're paying for a shaman. They're paying for all different ways to try to manage this problem, because medicine does not appear to be working to many of them. So the costs are almost double when you consider the overall picture. Hey, remember, they have emergency room visits, office visits, hospitalizations, tests, and hordes of procedures. They have had a lot of tests done to try to diagnose what they don't have. It's really more of a rule-out situation. Well, we didn't see anything on your x-rays. We didn't see anything on the CAT scan, the MRI, the nerve conduction velocity, the EMG. The blood tests, of course, were normal. So what do you have? You have a whole bunch of complaints that fall into this diagnostic criteria of the ACR. How does it impact on someone's quality of life? Hey, that's really important. So health-related quality of life, that's considered a functional outcome measure. You see here is HRQOL, health-related quality of life. On another functional outcome measure, the short form 36, which you're probably very familiar with. Again, any of these outcome measures that you're not familiar with, just go ahead online, download them at the various websites I gave you at the beginning of this program. So on the short form 36, people with fibromyalgia score the lowest on 7 out of 8 subscales versus people who don't have FMS. And they typically score about 4.8 out of 10 for perceived present quality of life. So kind of low on that scale. Quality of life issues are not scored accurately enough with generic functional outcome tools. And one of the main issues is that we see in the literature, these people are more than 3 times more likely to have depression. And is that being treated? Are they just being medicated, or are they actually getting support through social work or psychotherapy? Something very important to make sure your patients are being referred for. Okay, so what are they going to complain to you about when they come in? What's the presentation? Someone comes in, maybe their primary complaint is, oh, my neck hurts, I have a headache. But then you're starting to ask all your questions. Well, they've had generalized pain, not just the neck, but generalized pain throughout their body for over 3 months. The stiffness, especially in the morning. They're always tired. These are the people that go out and they get those great big diet sodas full of caffeine because that's what helps them get through the day. They're not sleeping well. And they've actually done tests looking at EEGs of the brain waves during sleep. They've done sleep studies and found they're not really getting normal restorative sleep based on the brainwave patterns. So this is not something they're making up. In the old days, people would say, oh, it's all in your head. All you could do is complain. We actually can see this now on testing. That sense of numbness, tingling, swelling, the fibro fog, they can't remember things as well, they're confused. Well, hey, if you're sleepy, guess what? You're confused. Brain's operating differently when it's too tired. Okay? And then the allodynia, the pain, hyperalgesia, being hypersensitive to painful stimuli. They're depressed. Gee, what came first, the chicken or the egg? Were they depressed and they got fibromyalgia? Or did they have fibromyalgia and that made them depressed? It's a good question, not yet answered. They are very hypersensitive. You might be having someone with FMS in the room and they're complaining, oh, the kid in the next booth is too loud. Oh, the lights are too bright in here. Oh, the hot pack's too hot, the cold pack's too cold. Everything is exaggerated. And that's part of that hypersensitivity. So they're not exaggerating to try to blow up their problem. They actually feel things on a higher level than normal. Their threshold for excitation in their nervous system has been lowered, and that's something that's been shown in research studies. So they're not making it up. Here's something that if you don't listen to people and question them carefully, if you don't get up enough confidence engaging with the patient, they might not tell you about common history of traumas, especially multiple traumas. Patients come in, oh yeah, I've been in 10 car accidents over the years, or people telling you all about their stressful situations. And if you listen very carefully, especially after I've seen a patient 2-3 times, and you're asking about their history, their background, did you have a stressful time growing up, was things tough for you? You often will hear about a history of some type of physical, emotional abuse of some kind, and that is very, very common and very well documented. Hey, nobody likes talking about this stuff, okay? People get uncomfortable, but you know what? It happens, and it needs to be addressed. And if that happened years and years ago, guess what? The effect of that trauma or abuse is still in the nervous system. The nervous system has memory. So, oh no, that was over 10 years ago. Well, guess what? It's still in the nervous system, and you'll see it reflected in the fibromyalgia. So don't discount it. Don't ignore it. I like to be reassuring to patients, and I like to make sure I provide them with the proper psychological support to manage this problem. Okay? So as we said, most medical tests are normal. They had blood tests, they had MRIs. Oh, we're not really seeing anything on this standard test done in the doctor's office. Now today they're doing a little bit more of a peek into looking at their thyroid issues. What else is happening with the fatigue? That's often an issue. Something to think about, asking, well, have you ever had your thyroid checked? There are very specific thyroid tests done, and you'll hear a little bit about that. They might complain about restless leg syndrome. My legs are always shifting, I'm always moving, I can't sit still. That's another whole syndrome in and of itself, but it could be a component of fibromyalgia. How about chronic pelvic pain? Who feels comfortable treating that? Well, that's something that's often a part of the aging process. Okay, pelvic floor muscles might weaken or tighten, and these people might present with urgency. Very important to have that managed. If the pelvic floor rehabilitation is not something that you are educated in, you might want to refer them to a specialist. Make sure they get checked by a urologist or gynecologist, depending on the patient, to see, is that chronic pelvic pain a matter of myofascial tension? Do they have a tumor? Someone might not have looked at that because it's very difficult for people to present and talk about. So again, lots of compassion for these patients when they come in, and lots of excellent listening skills on your part and documentation. One issue with chronic pelvic pain is interstitial cystitis, and that's those folks who complain about the bladder urgency or pain when they don't have any proof of having a urinary tract infection, but yet they feel like they do. So this is something that's treatable, and they should definitely see a competent physician who specializes in pelvic floor. One of the old-time diagnostic criteria for fibromyalgia is having pain in 11 of 18 tender points, bilaterally and above and below the waist. So now, this is a classic American thing. If you looked at Germany's criteria a few years ago, they said, well, there were 25 tender points. American College of Rheumatology said there's 18 tender points. And they're found in a classic chart, so you could check and see. What I found is that most typical people did have tenderness even if they didn't have fibromyalgia in the same tender points they talk about. So let's take a look. Take a look for yourself right now. So probably sitting in your chair watching the program, check out your lateral epicondyle here. Okay, is there any tenderness there? How about your occiput, the back of your head? Go ahead, be brave, palpate, poke around. C5 to C7 transverse processes. What's it like over there? That's the widest part of your neck down low. How about reach around, grab that upper trapezius. How many of you have a big trigger point up here? How many of you can play guitar up here? It's that tight, right? So very common. I've met so few people who don't have a trigger point or tender point in their upper trapezius. What about your supraspinatus, deep to that? Like one of your rotator cuff muscles. How about the pectoralis, especially here around second or third rib? Looking at the pec minor, check that out and see. How about gluteals? That's it, bend forward, get out of your chair a minute. What's going on in your butt? Is that hurting back there? So usually around the sciatic notch region. So that's another common tender point for fibromyalgia. What about the sides of those hips, the widest part of your hips, the greater trochanter? Feel the inside of your knee, just above the medial joint line of your knee, okay? So these are the 11 of 18 tender points that are classically painful in people with fibromyalgia. Now, I find it very interesting. Anyone out there familiar with Eastern medicine, Asian medicine, acupuncture? Well, if you show this list to someone who is a specialist in acupuncture and you ask them, you know, my patient hurts at all these points, what does that mean to you? Interesting. What's the answer I've received from teachers, professors of acupuncture? Stress and toxicity. When we look at the body from an Oriental medical perspective, we look at the body as a complex of systems that all integrate and function as a cohesive whole. Western medicine typically looks at the body as individual pieces. Oh, that joint hurts, let's chop it out and give you a new one. Or, oh, that belly hurts, let's give you a pill so we can cover up the pain so you don't notice it anymore. So it's not really looking at the whole person, it's treating body parts. Well, in the acupuncture system, areas that are acupuncture points are actually areas of reduced electrical conduction in the body. Reduced electrical resistance in the body. So you will find that many of those acupuncture points are tender, especially if there's an imbalance. And there are Oriental medicine diagnostic criteria by which if you check a number of points along the meridians or channels that represent the organ systems of the body, if those points are all tender in a specific constellation, well, that is part of their diagnostic criteria for an imbalance in the body. And these particular points that we call our fibromyalgia tender points are typical points that represent a problem of stress in the body and toxicity. So what is it we're really treating from an Eastern medical perspective? Stress and toxicity. Something to think about. Other comorbid conditions. So there's a lot going on with these people. Many complain about allergies, and not just allergies with the runny nose, but food allergies, chemical sensitivities. I have a lady I'm treating that, you know, she was so happy to get new rugs in her home, and she thought it was great, it looked wonderful, but as soon as she got the new rugs, you ever smell what these are like in the house? She became really ill, because whatever they used in the fabric of the rugs or the glue, she was allergic to, and she became very ill. She had to rip out all of the rugs in her house. How many people are sensitive to things like gluten? You hear that more and more. Oh, gluten sensitivity, you know, contributing to everything across the board related to digestive disorders. Okay, so have them checked carefully to what they may be allergic to. You know, that new car smell? Well, that's a toxin. That's not a perfume. So something to think about. Check to make sure that people don't have allergies. How about infections? Many people who complain of chronic fatigue, you know, their immune system's a little slow, they just say, well, okay, they have Epstein-Barr virus, or they have chronic fatigue. Gee, I wonder if it's really fibromyalgia as a component of that, because often they occur together. What about that post-traumatic stress disorder? You know, I ask people very careful questions about their past history. Have you had any unusual stresses, even years ago? It's something that gives you information about their condition. And of course, very common, back pain, neck pain, headaches, depression, sleep disorders. These are the classic fibromyalgia-associated conditions. So, chronic myofascial pain. Now, I'll often see people come in who happen to have fibromyalgia, but they came in because, oh, you know, I had a car accident, we had a car wreck, and I had a whiplash, and now, you know, my jaw hurts and my head hurts. So they're presenting referred for something else, but when you take their history, you find that they have this whole list of issues. So chronic myofascial pain is a very common component. We mentioned the GI disturbances, urological disturbances, pelvic floor spasm, reflux. I might be treating one of these folks, say, okay, I'm going to have you lay down now to do some tests. Oh, I can't lay flat. Why not? Oh, my back hurts. Oh, yeah, I get that little heartburn when I lay flat. Or sometimes, you know, the reflux comes up. So very common that they get what's called GERD, gastroesophageal reflux disease. Okay, heartburn for simple. So we mentioned the irritable bowel syndrome or IBS, and very common component of fibromyalgia, some type of thyroid problem, either over or underactive thyroid problems. And the latest research also shows an issue with their growth hormones. Now, something interesting about growth hormone. Growth hormone doesn't just make you taller. Growth hormone comes out at night when you're sleeping. Produced very much as your body is reconstructing itself as you rest. Well, in people with fibromyalgia, they don't produce the appropriate amount of growth hormone at night when they're sleeping. Growth hormone is responsible to come out and heal your muscles while you're sleeping. So why do they always complain about muscle pain? This is something interesting to think about. What relationship might that have to their low growth hormone? Let's look at a few psychosocial issues. It's a stress response. Okay, think about wherever you are right now. If the fire alarm went off and smoke is filling the room or someone's yelling, "Fire!" What would your reaction be? I can't imagine you'd be sitting here enjoying the show, okay? You'd probably get up, your system says, hey, it's time to run, let's get out of here, we don't want to burn to death. So you have a stress reaction, a very appropriate fight or flight response. Now that's called an alarm reaction. And you know that this is based on years and years of nature building into our bodies a protective response. Hey, there's a tiger chasing you, run. Oh, well, it ran you into a corner, fight. So either you're going to fight or flight response in response to something stressful. Now that's built into our systems for all of time to keep us alive. But many times people are having this alarm reaction or fight or flight response when there's really no threat to their life. How many of you have this problem? And I think it's becoming more and more prevalent in rehabilitation medicine. Okay, you have to write notes. So you finish treating a patient and now the insurance company wants you to write pages of notes and documentation. And of course it's different for every company. And so your boss comes to you at the end of the day and says, okay, I know you're finished treating all those 24 patients you just treated, and now I know the day is over, but you will now have to sit down and write your notes, and you can't leave until the notes are done. So you're overtime, but you're not being paid for overtime. Anyone feeling stressed? I'm getting a twitch just thinking about it, right? And I hear this all the time from therapists. Yeah, I have to take my notes home. I take my iPad home and I have to write notes and I'm spending hours doing that at night. So you getting paid for that? No. Are you getting stressed? Yes. So there's a stress response. Are you being threatened? Is your life being threatened? No. Or you're being annoyed by having to write a lot of extra notes you're not getting paid for. So your fight or flight response is flourishing. Now, can you fight the system or run away? Well, you might choose that. You might not have a job if you choose that response. So you hold the stress in, right? You know what that's like. Stress response, what happens? You get the stress response from annoying things like having to do too much documentation, and they're not going to pay you anyway. That can be very alarming. What about people who've had multiple traumas? What about people who've had abuse? Even things as simple as whiplash and concussions. Concussion's a big issue. Okay? This can create a stress response. We're going to look at the stress response in depth in just a little while, and I'm also going to give you a little bit of a practice item that you can use to help manage that stress response. How about hyperventilation? What happens when you're stressed? Do you take those nice, long, slow, deep breaths? No. The breath is up in your chest. You have shallow, rapid breathing. Hyperventilation. Carbon dioxide levels end up becoming low at rest. And there's a very poor breathing style associated with this. That actually has been shown to increase the histamine response in your body. Meaning histamines, the inflammatory chemicals in your body, the chemicals that make you more allergic, are increased by hyperventilation. So when your patients aren't breathing well, you need to think about, this isn't just affecting them right now. This is actually affecting their body chemistry, and it's making them more inflammatory. Something to keep in mind. Okay? Ultimately, if they have this stress over a period of time, they're going to eventually exhaust their adaptive capacity, and they're not going to be able to compensate for these problems. So we need to look very carefully at these psychosocial issues. What else happens? Well, when people become depressed, there's something in the body, there's a little neurotransmitter that you may remember, serotonin. It's one of those neurotransmitters that manages our sleeping and waking cycle. It's a little happy chemical. Well, people with fibromyalgia have very low serotonin levels, and that's affiliated with depression. Again, we don't know which came first, the chicken or the egg, but that's something that can be in part managed with antidepressants, things like amitriptyline, duloxetine, gabapentin is very commonly used in treating people with fibromyalgia, pregabalin, and selective serotonin reuptake inhibitor drugs, or SSRIs. So patients will say, you know, oh yeah, I'm taking these antidepressants, and they're wondering because maybe no one diagnosed them with depression. Well, bear in mind, antidepressants are used not just for depression, they're used for chronic pain to help manage the pain. So, and I mentioned already, of course, that fibro fog or impaired memory. Very easy for these people to get confused. So what else happens? Their actual threshold for stimulation for pain is lower than normal. Now, back in the old days, people would say, oh, they just exaggerate. They like to complain. Be a part of this. Their threshold for excitation has changed. And they actually found that in correlation with pain, there's reduction in blood flow to the caudate nucleus of the brain. So there's actually changes in the central nervous system itself. And that contributes to them having low resilience. They don't adapt real well. And there's a reason for it. Would personality type contribute to that? Absolutely. The environments that they have developed in, of course. Might genetics play a role? Absolutely. So you need to look and see, can they have some management for the anxiety or the depression? So definitely need a good referral for that. Pay attention to if they said they were under a lot of stress or are currently under a lot of stress. Think about how that changes the nervous system. Too much stress causes sympathetic dominance, that fight or flight response we talked about. It lowers the parasympathetic tone. That's our ability to relax, is through the parasympathetic nervous system. So what can we do to alter the sympathetic dominance that they're presenting? That's something we can work with, and we'll talk about this in today's program. Let's take a look at something very uncomfortable. What's the emotional outcome? What's the stress response from abuse? Okay, there's something called victimization, and it's actually called early developmental stress. People who have had abuse as young children have a very high level of chronic fatigue and fibromyalgia, and that's well documented in the research. Okay, higher prevalence of emotional neglect and abuse, not just physical abuse, but emotional, and also this has been something that tends to carry on through their lives. And I found this to be true as well in dealing with many patients I see who have fibromyalgia. Well, they grew up in an abusive situation, or oh yeah, their father beat them up, and their mother was a drug addict, and now they married somebody who mistreats them as well. And it just keeps replaying the same issue. So there needs to be special intervention here in terms of social work or psychotherapy as well. So think about if there's stress or abuse over a prolonged period of time, what does that do to the nervous system's arousal level? These people are in a constant state of arousal. They call it hypervigilance because it's the nervous system built in trying to protect itself. Okay, you leave those hormones elevated over a period of time, it overloads the sympathetic nervous system. Think about fight or flight response. What comes out? Adrenaline, cortisol, histamine. Okay, these are all running through the system. The body can't just keep producing these chemicals without eventually having a crash. I like to call it a sympathetic nervous system crash. So what is this HPA, Hypothalamic-pituitary Adrenal Axis hypersensitization? And this is what's now being well documented in the literature. We know about the fight or flight response, which was documented by Hans Selye. He called it a general adaptation syndrome. When you have repeated stresses and repeat, that repetition of stress will eventually cause the system to fail. And that's what we call general adaptation or maladaptation over time. So when there's combined stresses, it creates more dysfunction. Have you ever been stressed? Have to write a lot of notes at the end of the day? So something to think about. What's the autonomic response in the body to stress? Well, the heart starts pumping, right? So elevated heart rate. Blood pressure goes up. And you need to get blood to the muscles so you could fight or flight, run away. Right? Where does the blood come from? Well, the blood's being stored in your visceral organs. So when the blood comes out of the visceral organs, floods the muscles, getting ready so you can run away from that lion, tiger, or bear that's chasing you, what happens to your digestion? Something to think about. Why are people with fibromyalgia not digesting their food? Well, if they're in a fight or flight response, even if it's not a recognized fight or flight response, they don't realize they're in that reaction, stress reaction, the blood has left the digestive system. Digestion shuts down. Parasympathetic nervous system controls digestion. If it shuts down, they're not digesting the food is rotting in there. Maybe there's a reason they have irritable bowel and gastric reflux and gas and all of this, because they're not digesting their food. So very interesting. What can we do to help that stress reaction? Your muscles tense, they got full of blood flow. They're holding tension. Well, gee, if you did run or fight and you let the tension out by using your muscles, using up that adrenaline, using up that ATP that's flooded into your muscles, no problem. But what if you're just stressed and you're just holding it in and the muscles stay tense? And maybe they're not tense 100%, maybe they're tense 50% or 25%, depending on your stress level. What do you start to feel? It's like, oh, I feel tight here. Can I have a massage? Yeah, you're going to be ordering up a massage real soon. So that's that blood flow going to the muscles presetting tension. We need to be able to release that tension. And that's something, if you work in rehabilitation, probably an expert at doing that. The hands get cold and sweaty because the sympathetic nervous system is in overload. The mouth gets dry. You know the feeling. So that's the stress response. Imagine if that was just continuous at maybe a low level. Very classic with fibromyalgia. Continuous, eventually the hypothalamus, pituitary gland, the adrenals, they wear out. They can't just keep pumping out the cortisol. Can't just keep pumping it out. So what happens? You run out. You need to take a chance to rest. These people have a crash. Oh, I'm so tired. I just crashed out on the couch. What can we do to help rebuild the system? Give them a chance to rest. Give them more restorative sleep. Give the muscles a chance to relax and energize again. Give the digestion a chance to work. How long can a body maintain this level of alert? Well, depending on your genetics, some people more or less. Okay? So stress reaction, what else happens? The stress reaction, your body secretes ACTH, adrenocorticotropic hormone. Serotonin is secreted. But what if this continues on and on and on, and serotonin just keeps getting secreted in response to stress? What do we say about fibromyalgia? Oh, they have low serotonin levels. You think they might have run out from having had that alarm reaction enduring for too long? Something to think about. They run out of endorphins. What's a great pain management neurotransmitter in your body? Endorphins. Okay, they're running out of that. Prostaglandins, inflammatory chemicals, adrenaline, glycogen, energy. Okay, so how do you know which system's going to break down? Well, your genetics tells you a little bit about it. Okay, there's an actual neural network dysfunction through your master glands, hypothalamus, pituitary, adrenal, as a result of having this chronic stress reaction. What else do we have? Elevated substance P. Substance P has to do with pain. It amplifies pain perception. Why are these people so sensitive to pain compared to your everyday so-called normal patients? Okay? Why don't they sleep well? Well, low serotonin. You need lots of serotonin to have a good night's sleep. Okay? Low tryptophan also amplifies their pain. You know, you're probably familiar with tryptophan from Thanksgiving dinner. Turkeys have lots of tryptophan, and they tell you that that's what made you fall asleep after dinner. Well, they don't have enough tryptophan either, so maybe that's contributing not only to the pain, but maybe to the sleep issue. So there's basically a central sensitization. It's an actual change in the nervous system from repetition of this afferent, painful input. So what can we do? What do you do in the clinic to help manage stress for yourself or for your patients? Okay? How about just breathe? Just right there in your chair. Take a deep breath. Close your eyes. Take a slow, deep breath in and out. Do a couple of those. I usually like to tell people, you know, when you're undergoing a lot of stress, take some 2 or 3 real deep, slow breaths. You know, stop the stressor. If you're in a situation and you can remove yourself from that stressful situation, great. If you can't, well, that's a different problem. Okay. Can you learn to respond differently to the stress? Here's something not taught in school that should be taught in elementary school. how to manage stress. That's not discussed until people get to adults. Well, kids have stress too. I think we should start teaching this to children. Okay? People can learn to be more resourceful. You have two different people in the same stressful situation. And I'll go back to 9/11. I had a friend who was a professor working in the same place I was working. And the day after 9/11, she was so calm, cool, and collected. She's like, oh, I'm so grateful. We got a ride across the Brooklyn Bridge. We got home safely. My family was safe. You know, as horrendous as it were, you know, we're very blessed. She's very calm. Now, I had another friend who's a Wall Street broker. Big guy, works out, macho, nothing bothers him. He was losing control the next day. I am not living in Manhattan. Literally, he bought a place in Pennsylvania the day after 9/11 so he could move away from New York because he was so stressed. Now, why did these people choose to respond differently to the same situation? They both made it through. They were both okay. Needless to say, it was horrendous. But why did they respond differently? Because one learned how to respond with good resources and the other did not. So a lot of this reaction is a choice, and people don't realize the emotional reaction is a choice. It's not something that you have to react to. And you can learn to respond differently to a stressful situation. Stress management courses, behavioral management, therapy can be very, very helpful. And this is something that people can learn and practice. So how can we help? Simple. Something you probably already do, teaching patients that deep breathing technique, that diaphragmatic breathing technique. How about teaching focus? Some people call it mindfulness practice or meditation, or focus or concentration. Whatever you call it, it's very helpful to focus on a single sound or a thought, or some people look at a candle, picture a star, just to have a singular focus and let all the other thoughts float away. So some people call that mindfulness or mindfulness practice. How about exercise? Most of us like to teach our patients exercise, like aerobic exercise. That releases the excess pent-up energy. You have all that blood flow in your muscles, all that muscle tension from holding in the emotional tension. Let it out. Get out there and take a run, take a walk. You know, some of your patients can't really run. They're not in the shape to run. Maybe they have arthritis in their knees or something. Get them on a bicycle. How about a pool, some warm water exercise? Some kind of aerobic exercise, even a nice walk, to ease the muscle tension. And of course, some of the work that we do. Great massage, great myofascial, manual therapy work to ease the tension that they're holding in the muscles. Okay, so there is definitely help for the stress reaction. Cognitive behavioral therapy is commonly practiced by people who are psychotherapists or social workers or psychiatrists, and this is very, very helpful and has been shown to have reduction in some of the symptoms for fibromyalgia. So I like to refer for cognitive behavioral therapy. In my office, I have biofeedback machines that can tell a patient when they're holding tension and when they're relaxed, because people aren't focused on that. They come in, their shoulders are wrapped around, their ears are so tense, they don't even know it. They're like, hey, relax those shoulders. I'm like, oh, I didn't realize I was holding. Biofeedback can be used to help them to see where are they holding tension. So there's biofeedback for temperature, galvanic skin response, sweat response is biofeedback for muscle tension, all different styles available. How about movement therapy? Pilates, Feldenkrais, all different kinds of movement therapy is available. Tai Chi, yoga, to help people get in touch with their body and reduce some of their abnormal muscle tension. So there's tons of classes out there in stress management, stress reduction. A lot of people don't like to say, oh, I need to go to psychotherapy. They think, oh, what's wrong with me? Everybody can benefit. When you're having a stressful issue, it's good to find the resources to help manage the deleterious response to stress that's in your body and to help get resources. There's all kinds of access to resources online, so do feel free to check it out. What else happens with stress and fibromyalgia? Wow, immunoregulation issues. This is something. And the immune system is being very widely researched now, and we're learning more and more about it. And you may hear these people complaining about their food allergies or food intolerance, whether they're allergic to tomatoes, allergic to gluten, have a certain sensitivity to corn. You know, how many of you have been in an airplane and they said, okay, we're not handing out peanuts today? And one time I took a flight, I didn't bring any food with me, and I was so looking forward to getting that little bag of peanuts. They said, oh, we're not serving peanuts today because somebody on the plane is allergic. Like, oh, great, didn't you have anything else? And this is something that can be very critical for people if they have a severe allergy. And the problems with the immune system and allergies are a very common component for people with fibromyalgia. And not just the food, but what's in the food. So many chemicals. MSG. I have a patient who's so allergic to MSG, if that's in the food, it will cause his heart rate to race and blood pressure to go up. And he's on heart medication, so that could be dangerous for him. And many restaurants won't even tell you if there's MSG in the food or not. Aspartate, okay, NutraSweet. How about some of those various sugars? You know, they're not, a lot of times people will say they're real sugars. They're really fake. And they're also neurotoxins. These are called excitotoxins. They're toxic to the nervous system. So, you know, if you're doing that diet soda right now, take a look at what's in there and decide, is that something you really want to put into your body? Something to think about. Some of this toxicity is acquired. If you have too many toxins in the system, your liver might be able to handle a certain amount, then it goes, cup runneth over. You know, the liver can't handle all of that excess. How about nutritional deficiencies? One thing to have an excess with toxins, how many people might have a folic acid deficiency because they have irritable bowel syndrome? They're not absorbing their vitamins correctly, so they're tired. These are things to think about. B12 deficiency is very common. So this is something you definitely want to refer for nutritional testing with a competent physician. Some people have certain blood type intolerance. The dietary lectin is one issue. Mycoplasma, fungal infections, viruses, bacteria. There's many people in the complementary medicine field with concerns about candida and high sugar levels, contributing to parasitic fungal infections. So these are some things that you might want to ask. Have you ever been tested for food intolerance, parasites, fungi, things like that? In Great Britain, they actually call this problem myalgic encephalomyelitis. There's the mouthful. What else do they have? Decreased growth hormones. We mentioned that growth hormones come out when you're sleeping, and they help to repair and rebuild your body during its resting time. Well, people with FMS don't have enough growth hormones. And they've also been documented to have low ATP and ADP. Remember the Krebs cycle? ATP, the power molecule, makes your muscles contract. Well, they don't have enough. So no, they don't want to do your stinking exercises because they don't have enough energy to manage. How can we pick up that ATP? How about exercise? Something we could do about that. They also have been shown to have elevated cytokines, inflammatory cytokines from white blood cells. And these are produced in diurnal rhythm. So there's actually a biorhythm, a circadian rhythm, where these are produced. And how is a circadian rhythm in someone who's not sleeping well? It's disturbed. So there's multiple systems being involved here. Immune abnormalities are documented for people with fibromyalgia. Interleukin-8, these are some of the immune transmitters. Interleukin-8 is doubled in fibromyalgia, which actually causes increase of pain through the sympathetic nervous system. Interleukin-6 increases the stress response, makes them more depressed, feel pain more readily, makes them more tired. Okay. Interleukin-1 RA is also doubled in fibromyalgia. So these sleep rhythms are something that's being investigated more carefully now and has a lot to do with the production of cortisol. Remember our stress hormone, cortisol, versus cytokines. And there are changes in levels of cortisol versus cytokines in the body that relate to one another. And it changes over time with your circadian rhythms. Now, people say they have worse symptoms early in the morning. Well, that's also part of that circadian rhythm cycle. This is what's being more carefully investigated now. What can we do to help them get a better night's sleep? I mentioned that the thyroid is often involved in fibromyalgia. Diet influences the thyroid, of course. So do they have enough iodine, tyrosine, copper, zinc, some of the trace minerals, selenium? Okay. There's also a thyroid hormone resistance associated in the research with fibromyalgia. So I'll ask people, what's your diet like? make me a log between now and the next time you come in for therapy and tell me what you're eating during the day. For most of these patients I see, there's not a green item on the menu. It's diet soda, it's white flour, white pasta, white sugar, and they're eating in a hurry, they're not digesting their food. Where's the surprise here? So I like to refer them immediately for good nutrition. Metabolic therapy has been shown to be helpful for people to be able to lower the amount of drugs they're taking to manage their fibromyalgia, particularly antidepressants and nonsteroidal anti-inflammatory drugs. What about those digestive issues? Irritable bowel syndrome, that alternating diarrhea, cramping, gas, constipation, bloating. They don't find anything if they have a colonoscopy or upper or lower GI series. Everything shows normal. There's no pathology, but it's something that's symptomatic. Okay? Some people have found that removing gluten from their diet, wheat, dairy, or certain other foods, artificial sweeteners as we mentioned, has been helpful to reduce the irritable bowel syndrome. Some people have a history of taking lots of antibiotics. And this is something more common that you hear about is, oh yeah, eat your yogurt or take your probiotics so that your digestive flora, your microbiome in your digestive system, all those little cooties that live in there that keep you healthy, that help you absorb your water back into your system, well, those can be thrown out of balance by too much antibiotics, certain types of foods that aren't healthy for you. So these are something you want to ask people about and, of course, refer to an appropriate person for diet and nutrition. So up to half or 89% of incidence of irritable bowel syndrome in people with fibromyalgia. So it's usually present. We talked about stress and digestion. Well, your fight or flight increases your heart rate, increases your blood pressure. Respiration becomes shallow and rapid. Well, you use your diaphragm muscle for respiration. That actually acts as a piston. When you breathe in, your diaphragm pushes your digestive organs down. You breathe out, it recoils, and it goes up. So there's actually a massaging action that your diaphragm creates in your digestive system. If you're not breathing deeply, normally, you're losing that massaging action that helps the peristalsis. Something to think about, just purely physiological. Also, when stressed, we said blood leaves the digestive system, goes into your muscles. So how could you digest your food if the system's shut down? So this is something you have to think about and make sure, what can we teach people to help reduce that stress reaction, help them digest their food better? Relaxation, deep breathing. Okay. Many of us are movement practitioners. What about those biomechanical issues? Well, interesting and sometimes surprisingly, they've shown that hypermobility is very common in people who have fibromyalgia. Now, I typically like to see people with hypomobility. It's easy to stretch, give them programs, very manageable. But hypermobility or instability, another issue. Often they have a deficiency of exercise. Oh, it hurts to exercise, so they're out of shape. You don't use it, you lose it. So now it hurts for them to start to get back in shape. On top of the pain they already have, they're not interested in complying with your exercise program. All those traumas that they might have accumulated, okay? Physical, mental, accidents, emotional traumas, the tension in the muscles. Make a fist real tight. Hold that fist real tight. Are you doing it? Check it out. Hold it. Don't open it. If I told you to wait until the end of this program to open your fist, that's about an hour from now, what would happen if you tried to open it then? Now you're peeling your fingers open one by one. Ooh, they're going to be so stiff and sore, aren't they? From holding. What are you doing with the tension in your muscles? And typically it's those emotional muscles of your face, neck, your breathing muscles. Those are the ones you're holding tension. Why are they getting headaches? What can we do to release that tension? Okay. Patients start to associate pain with trying to move again after they haven't moved for a while. Oh, it hurts when I'm stiff. It hurts to get moving. Yeah, but you have to work through that to the best degree tolerable, because that fear of having pain with movement makes them stop moving and just compounds the situation. Okay. What about the posture? How do people hold themselves? Well, if they don't feel happy, what's the posture like? What if they're angry? What's the posture like? What was your posture like the day you graduated? Yeah, totally different. What's your posture like when you're relaxed? So looking at someone tells you how they feel, doesn't it? Based on their posture. How about changing people's posture and noticing that actually changing their posture will change how they feel. Interesting. So if you have other people around in the room there with you, look around. What's the posture like? Look at the posture on your patients when they don't know you're looking. Because if you tell them, oh, I'm going to check your posture now, everybody's a Marine, right? Everybody's got the perfect posture. So biomechanical problems happen as a result of poor posture, and breathing is a key thing. When we're stressed, we don't breathe deep enough, we hyperventilate. So normal breathing rate is 12 to 20 breaths per minute. Hyperventilation is at rest greater than 20 breaths per minute, okay? That can be related to stress and anxiety. Poor posture, people with the forward head posture, and everybody's texting at the forward head posture. What happens to your breathing muscles? What happens to your accessory respiratory muscles? They shorten and get tight. What happens when you're stressed? Teeth clench. Can you breathe normally if you're busy holding tension through the neck and jaw? Of course not. So there's going to be a problem with this hyperventilation from stress. Overuse of your postural muscles causing tension. I have patients come in with, oh, my hand's numb, thoracic outlet syndrome, from holding so much tension in their accessory respiratory muscles. They're thinking it's a problem in their hand. Meanwhile, I'm finding it's a problem with their breathing and their diaphragm. So we need to teach relaxed, deep breathing techniques. Hyperventilation will lead to respiratory alkalosis or acidosis. You get tetany in the muscles. Too much anxiety, okay? Myofascial tension, shortness of breath, dyspnea, okay? That can lead to confusion because now you're lowering the oxygen level to the brain. That's present in 57% of people with fibromyalgia. Now, if you want to assess a functional outcome measure, you could use the Nijmegen questionnaire. You can, again, download these online to assess whether they're hyperventilators or not. And it's imperative to remove the strain and correct the breathing. So rapid shallow breathing, bad enough that it tightens up the neck muscles, can give you a headache, can give you thoracic outlet, any type of problems with cervical strains and sprains, okay? But it can also give you weak pelvic floor muscles. When you breathe in, your diaphragm descends, your pelvic floor diaphragm also descends. So if you're breathing shallow, you're not getting that normal pistoning action of your respiratory and pelvic floor diaphragm. Okay? Think about the spine, neck muscles, thoracic muscles, diaphragm restrictions. All this hypertonicity can lead to myofascial pain as well. Think about your accessory respiratory muscles attaching all the way up to C2. They've shown that restrictions of your second cervical vertebrae can contribute to vagal disturbances, disturbance of your 10th cranial nerve, the vagus, which could make somebody dizzy, could make them nauseous. Lots of issues. How about that sleep? Getting a good night's sleep? Well, there's non-restorative sleep that's associated with fibromyalgia. Okay, is the most common complaint along with the pain and fatigue. So they actually don't have the normal delta sleep pattern. Your brain waves go through certain patterns at night. They have more of an alpha wave pattern, a more alert pattern, and they're not getting the rest. So that's one of the reasons docs like to give antidepressants, because it improves the sleep and improves the serotonin. A good meta-analysis, high level of clinical research, shows the benefit of improved sleep with less stiffness and less tenderness in those tender points for people with fibromyalgia. Low growth hormone we talked about, well, if you're not getting good sleep, you're not getting out that good growth hormone that helps rebuild your muscles and repairs you at night. Okay? They have interleukin-1 deficits, adenosine metabolism is lowered. Okay? In the brain, low brain glucose increases secretion of adenosine. Okay? Lowers the ATP levels. How do they contract their muscles? How could they be busy working if they're too fatigued because they're out of ATP? Why don't they want to do your exercise programs? Why won't they comply? There are good reasons. So, interesting to think about. How do we build ATP? Exercise. Get them out there. Okay, a little relaxation. There's a little break for your mind there, a little spa out in Colorado. Hot water in the middle of the snow. How about some lifestyle changes to de-stress? We talked about proper diet and metabolic adjustments. Okay. How about getting adequate rest? If it's necessary for them to take a medication to do that, go for it. I like to teach my patients regular aerobic exercise, starting with small bouts below the pain threshold. Remember, these people coming in sore to begin with, they're tired, they're sore. The last thing they're interested in is exercise. And I tell them day one, you've got to exercise. It's going to hurt in the beginning. I'll ask your doctor, can they help manage the pain? We'll do some hands-on techniques to help manage the pain, but you've got to get going with the exercise. What is aerobic exercise? Huffing and puffing, using large muscle groups. These people aren't about to be out there running, but you could do some general calisthenics. A lot of people like warm water pool exercises. How about just some biking? But you need repetitive motions using large muscle groups, huffing and puffing, at least a good 20-30 minutes continuously. How about to de-stress using manual therapy? Trigger point release, neuromuscular re-ed, myofascial release, cranial sacral, massage, stretching, strengthening programs. What about meditation techniques or relaxation, deep breathing techniques? Need to be integrated as part of a daily routine. Okay? Think about it. When someone's stressed, put the word stressed in a mirror. What does it spell backwards? Desserts. Maybe we should all be eating more dessert to feel less stressed. Only kidding. But just an interesting thing to think about. We mentioned cognitive behavioral therapy. Okay? It modifies the thought pattern, teaches people different ways to think to help alter their behavior. Stop magnifying their symptoms. Stop overgeneralizing or focusing on the negative. So they found that there was a vast improvement in functional status in people with fibromyalgia after just having 4 weeks of cognitive behavioral therapy. Hey, that's not a long time. How about relaxation training? Deep breathing exercise, guided imagery, meditation, mindfulness, autogenic training, biofeedback. It's all the same stuff. It's focus and breathing. Mindfulness meditation has been looked at in a randomized clinical trial, RCT. This is a little bibliography here for you. They took 49 subjects, taught them mindfulness stress reduction training versus just a healthy control of listening to music with nutrition, walking, balance, core exercise, and agility exercise. They did this over an 8-week period. They measured the Trier social stress test score, and cortisol cytokine response to stress are also measured. What did they find? Hey, in the mindfulness group, meditation group had significantly lower inflammatory response, measured literally by cytokines in the bloodstream, interleukin-8 and tumor necrosis factor alpha, lower than the control group. So we can see actual changes in the body chemistry as a result of the meditation. Try it for yourself. Now, you can spend some time doing this for more time, but just if you want to try for a minute or two right here now, try some deep breathing with visualization, some focus exercise. So sit comfortably or lay down if you like. Put one hand on your chest, put the other on your abdomen. Just breathe normally and observe. As you're breathing normally at rest, do you feel more of the chest hand moving or the belly hand moving? Well, the belly hand's supposed to be moving more because you should be breathing using your diaphragm. If you felt more of the chest hand moving, you're using your accessory respiratory muscles, you're using a slower, more rapid breathing pattern. Why not relax into just spend a few moments holding a hand on the chest and belly just lightly and just visualize breathing, letting your belly relax, breathing deeper into your belly. Not forced, not hard, but a soft, just allow the belly to fill with air. Breathe in and allow the chest to be more relaxed. So a little relaxing picture of out in Austria there for you. So practicing mindfulness, deep breathing is very helpful, using more diaphragmatic motion, less chest and neck expansion motion. Okay? You want to relax your shoulder and chest. No force. Some people call it physiologic relaxation. Basically, it's about being quiet and letting your breathing be relaxed. Now, as you're focusing on your breathing, many times you'll notice that all kinds of thoughts fly by. Oh, I forgot to turn off the cell phone. Oh, I have to pick up the kids after school. Oh, I better pick up that quart of milk after work. And the thoughts just float through your mind. Ignore them. How many times you watching a TV show, the commercials come on, you could ignore them. You're not interested in the commercials. You're interested in the show. So you change your focus. So your mind is a little show going on. Ignore the commercials. Ignore the background chitter-chatter that's perfectly normal that everybody has. Focus on one thing. Maybe music, maybe a sound, maybe a candle, a flower, anything, something very mild. Just let the thoughts go by and keep a single focus. I like to picture a star or sunshine. Some people like to picture, oh, I'm just sitting at the ocean with the waves or in the mountains, whatever you like. Keep that focus and continue your quiet breathing and focus. You can measure the changes yourself when using these techniques with yourself or a patient. Check the pulse rate, check the blood pressure, check the respiratory rate. If you have biofeedback, GSR, skin temperature. Do take some measures. You'd be pleasantly surprised you see a change within minutes. So research on biofeedback shows a combination of heart rate variability biofeedback, breathing at a rate of 6 times per minute, that's half the normal rate, really slow, and mindfulness meditation improved that irritable bowel syndrome we talked about. Another pilot study done by Hassett, 10 sessions in 12 females improved most symptoms of fibromyalgia: sleep, pain, fatigue, depression, and overall functioning. Not bad. How about exercise? Aerobic exercise 3 days a week. 65 to 85% of your maximal heart rate. That's aerobic exercise using large muscle groups. 15 to 20 minutes. Remember, when you're first using this on patients, you need to build it up gradually. I might start them with, 2 or 3 minutes on the bike, take a rest. 2 or 3 minutes on the treadmill, take a rest. 2 or 3 minutes on the arm cycle, take a rest, with a little warm up and cool down. Each time they come, increase the time of the exercise, decrease the rest till they're doing continuous exercise. By all means, avoid overexertion in people with fibromyalgia. They will be terribly sore the next day. And in the beginning, you might want to work on some pain management with them, because when they first start exercising, yes, they will be sore. Let them know ahead of time this is to be expected. We will help you manage that pain. That will pass when they get a training effect, which may take a couple weeks. So aerobic exercise, whether using treadmills, bikes, swimming pool, whatever. Here's a randomized clinical trial looking at 36 patients with fibromyalgia from 18 to 70. Separated them into 2 groups. Twice a week for an hour for 12 weeks. Group 1 did graded fitness, bike and treadmill exercise. Group 2 did flexibility and relaxation training, visualization, cued relaxation. They checked to see 3 months later, okay, they had lower trigger point, lower tender point counts for up to a year. Remember we talked about all those tender points they have? Well, they were lower, and that consisted per year. 12 months after the study was over, only 55% of the subjects still had a diagnosis of fibromyalgia. And they used the Fibromyalgia Impact Questionnaire, FIQ, the McGill Pain Questionnaire, and trigger point count. Good news. How about the effect of exercise on trigger points? TPs, tender points, trigger points. They did a meta-analysis, high level of clinical research of randomized clinical trials and said, let's compare aerobic exercise, strength exercise, and both on the painful tender points in adults with fibromyalgia. 322 subjects, N is the number of subjects, over 8 studies in this meta-analysis, and they found that it was reduced by a statistically significant amount for the painful level of the trigger points. And those who complied with the exercise, reduction in trigger point pain was about 11%. More exercise research. There's moderate quality evidence for aerobic exercise, short-term effectiveness on both global well-being and physical function for fibromyalgia. Less rigorous studies showed good effects of strength training on trigger point pain, depression, global well-being. We do need more studies. So exercise is an option. Last thing the patient wants to hear when they walk into your office. But if you square with them day one, look, I'm going to get you exercising. You might not like it in the beginning, but as you get used to the exercise, get a training effect, just like athletes get stronger. You'll get stronger, you'll be more fit, you'll have more energy. You can do more stuff with less pain. How does that sound? Lifestyle physical activity. They took 2 groups of people with fibromyalgia. Group 1 did some self-selected physical activity throughout the day, up to a half hour. Group 2, the control, just got some education. The activity group decreased their Fibromyalgia Impact Questionnaire scores by 18%. That means they did well. And they increased their walking steps by more than half, 54%. Unfortunately, it wasn't maintained 6 to 12 months post. Why? Because you have to stay in shape. You don't use it, you what? You lose it. The activity group, though, did maintain their increased steps per day by 44%. So some carryover. How about just some simple lifestyle adaptations? Start the physical activity in small amounts. A few minutes of different activities as tolerated. Add it to their lifestyle. It's part of their day, 5 to 7 days a week. Have them work up to a half hour of continuous physical activity. Let me tell you, most of these people are pooping out in 5 minutes. And if you think about what happens in exercise physiology, if you're familiar with physiology, within 3 to 5 minutes of a continuous physical activity, using large muscle groups, such as walking, okay, what happens? Your body switches from anaerobic to aerobic metabolism. If these people don't have enough ATP, they don't have good aerobic metabolism, you need to build it up for them. That's telling you the problem they have. So you can build this up. I like to give them something to track their progress, a pedometer or something, so they can see themselves getting better. Let them choose activities they like. Some of my patients I'm treating currently with fibromyalgia, they love dance. So they have their little dance videos, they got the Wii with the dance or whatever, and they know they could participate in something they enjoy. Another client I'm thinking of enjoys group activities. So she goes to the local library and they have a Tai Chi class. So she's got that slow, gentle movement. There's a group of people. It's kind of fun. She gets out. She loves it. And so she started that class doing less than 5 minutes. I saw her recently just grocery shopping. You're talking at least a year later. She's doing full 1-hour Tai Chi classes nonstop several days a week. And she loves it. Where when she first started, oh, I got to stop and rest every 5 minutes. I can't keep up. Things change. Give them a chance. Relaxation. Who's all for that, right? Nothing like a beautiful day. So think about adding to their routine, not just exercise, but relaxation. How about flexibility training? Stretching, basically. They did a randomized clinical trial comparing strength to flexibility training, and they found improvements in several measures in the flexibility group, but not as big an improvement as in the strength group. What did we say earlier? Hypermobility was a more common problem with fibromyalgia. So stretching might feel good, but do you want to make them more hypermobile? I don't think so. I think they need some stabilization, some strengthening. And this study shows there's symptom-related self-efficacy, the strength in shoulders and knees, upper body flexibility improved in both groups, flexibility and strength training, but better in the strength training group. How about Tai Chi? I was just mentioning a patient who's a big fan of Tai Chi. He has a randomized clinical trial, 12 weeks in 66 patients. They had 2 sessions, either Tai Chi or a control with simple wellness and stretching. Tai Chi group had substantial increases in their fibromyalgia impact questionnaire scores and their short form 36 scores versus the controls. Found out that 24 weeks later, they maintained that improvement in the Tai Chi group. So quality of life, symptoms improving with Tai Chi. Another study looked at lower extremity flexibility improved, also with Tai Chi. There's tons of Tai Chi programs out there. They're in your adult ed programs. They're in your libraries. Many of them are free. So help your patients to access some of these programs. Some people love yoga. Randomized clinical trial of 53 people. Okay, 8 weeks of yoga versus just standard care and controls. Several measures improved in the yoga group. Coping was better, pain was better, sleeping was better, less tenderness in the tender points, less fatigue, better memory, wow, less depression, better balance, no surprise there with yoga, and less anxiety. How about water exercise? Oh, my folks with fibromyalgia love those warm water-based pools. And many places will have these aquatic therapies available, whether it's a local Y, a local therapy office, or some of the high school or college pools have it. So we know that that warm water-based exercise is really great for improving function. Even if it's just mineral baths, I tell people, get some of those Dead Sea mineral salts or, some nice Epsom salts, put them in your bath and just enjoy. It relaxes the body, relaxes the muscles. So nice benefits shown across the board. How about the manual therapy? How about some of the work that we do, right? 3 cheers for that. Massage, myofascial release, okay? Now, here's something very important to think about. No deep work with your manual therapy or massage with patients in fibromyalgia, especially if they're in that flare-up stage, okay? You need to keep the light massage and myofascial therapies going. Deep work will cause an inflammatory response. I've seen that with patients. I've made that mistake. I've had numerous patients come to me because they said, oh, the other therapist worked me too hard, went too deep, I was miserable, I'm never going back there. Got it? Light. See what they tolerate. Lymphatic drain is very good, strain counterstrain, trigger point treatments. There's alternative therapies as well. This is something you're familiar with, great. Otherwise, you might want to educate patients, look into some Tai Chi, acupuncture, chiropractic, okay, hydrotherapy, the water therapy, herbs, dietary supplements. A lot of people going on special detox diets, introducing a lot more green foods and whole foods into their bodies and less of the processed foods. Okay? In a systematic review and meta-analysis, again, a high level of clinical research, most of these complementary medicine interventions are very promising. but we do need more studies. Detox diet. Okay, vegan diet has been shown in studies to improve sleep, pain, stiffness, and health for people with fibromyalgia. Less symptoms when eliminating those excitotoxins, aspartame, MSG. So these are things people could try just from a health level. How about hypnotherapy? I happen to be a hypnotherapist as well and use hypnosis for pain control very successfully. It helps with patients who aren't responding to other means. Homeopathy. Not something I practice, but I know some osteopaths locally who are homeopaths, and they've shown in the literature something called Rhus-Tox has been recommended in a 6C dilution. Again, do not recommend these things to your patients unless this is something you're trained in. I refer to a physician who is trained in homeopathy to manage this, because it's not something I do. Just showing you what's out there in the literature. Bath therapy, officially termed balneotherapy. Hot tubs, nice baths, soaks, okay, can also improve symptoms. There's all kinds of nutritional supplements. Again, these are things I refer to, something to think about. Learn more about it. Okay. They did a systematic review that showed that a combination, what did we say, multifactorial programs, multidisciplinary programs are very important. Aerobic exercise, cognitive behavioral therapy, antidepressants like amitriptyline, multi-components are most recommended by professional associations in both America and Europe. Again, as you know, systematic review is considered one of the highest levels of clinical research. Here's another one, criteria. Patients coming in, they only looked at studies which were randomized clinical trials of people with fibromyalgia, and they compared 11 alternative therapies to controls. What did they find? Well, they chose about 60 studies, and they found mind-body therapies and the bath therapies were very effective for fibromyalgia. Some of the others, promising, but they need more research. So we already know the mind-body works, that's proven, and the bath therapy is also proven. Here's another meta-analysis of some interventions. They compared 49 studies here, drugs versus non-drug studies. Non-drug interventions were more efficacious for self-reported and functional outcome improvements versus drugs alone. So you can't just throw a drug at somebody and put a Band-Aid on the FMS. You have to address their issues. Antidepressants were best for improving physical symptoms in 4 categories, and exercise alone did not make a significant impact. Okay? It has to be combined. They looked at research on fibromyalgia, interesting, muscle fiber size distribution and muscle fatigue. Healthy postmenopausal females, okay, 11 with fibromyalgia versus 11 healthy. They did a fatiguing exercise program, and let's see, comparing the 2 groups on self-reported questionnaires. Loss of strength and tissue oxygenation was measured, and biopsies, looking at SDH, succinate dehydrogenase, there's a mouthful, to look at the post-exercise fatigue. What did they find? No significant difference between the groups on muscle fatigue response or percent of that succinate dehydrogenase, positive or negative fibers, or cross-sectional area. However, interesting find, less capillary density in people with fibromyalgia, meaning less circulation. Interesting. And a higher percent of SDH fibers. Okay? Healthy controls did best with the higher percent of SDH fibers. Multidisciplinary approach is needed. Again, another study review talking over 1,000 subjects. Treatment combining at least an educational or psychological therapy with at least one exercise therapy. Okay? You're handling the pain, the fatigue, and the depression. Physical fitness benefits also tend to carry over on the long term, which is awesome. So compliance with the protocols, you're going to have to talk people into doing this. It's hard to get them started, but once they get over the hump and they start to see those changes, they're interested. So patient education is the key. Explain the interventions and measure the results. Use your functional outcome measures. And here in this slide, you have the Fibromyalgia Network. Fabulous free support information. There's support groups all over the country. So check out the Fibromyalgia Network. I've given you all of their contact information. Tell your patients about it. So if you want to improve compliance, you want them to go with the program, you've got to show the evidence. I've given you a good part of the evidence right here. You need to be supportive, you need to be compassionate, you need to be a good listener. Okay, communicate. I tell my patients, look, if you're having trouble at home, maybe I'm away teaching somewhere, here's my phone, call me up. Shoot me an email. You got a problem, I'm going to get back to you. They need some coaching. You know, they've been through a lot of other practitioners that didn't help them. They're not about to trust you right off the bat. I also have a list of patients who had fibromyalgia with successful management who agreed to give me their names and numbers or contact emails. Oh, you can pass my name on to other patients you have, no problem. Especially folks in the Fibromyalgia Network, very willing to do that. So let them know too. How many years did it take you to get this problem? It's not going away tomorrow. This is a process. Would you rather undergo 4 to 6 weeks of exercise that's going to feel bothersome and uncomfortable at first in order to get some results? So yeah, you're going to feel more uncomfortable for a few weeks. But that's going to make you more comfortable and functional for who knows how long after. Versus you're not going to exercise, you're not going to do any of the therapies, guess what? You're not going to get better, you're just going to live with the pain. So you need to have a lot of compassion and to show that you have results. So the integrated approach to healing, I like Hass's comprehensive approach. Exercise, psychiatric approach, regaining function, education, stress management's a biggie, and sleep hygiene. Got to get that good sleep. Giving you some educational websites to check out. Really good stuff is out there, especially the myalgia.com and the fmaware.com. Okay, we're done with fibromyalgia. Ready? This is a lot simpler. Myofascial pain syndrome, MPS. This is defined by Dr. Janet Travell and David Simons. It's basically pain and or autonomic phenomena. Interesting, see, not just about the muscles. Autonomic phenomena referred from active myofascial trigger points with associated dysfunction. The specific muscle or muscle group that causes the symptoms should be identified. So this is all about the muscles and their associated fascia. It's not necessarily about the emotions, all the body chemistry changes. This is very, very distinct. Many terms for myofascial pain syndrome: muscular rheumatism, myositis, myalgia, fibrositis, myofasciitis, myalgilosis. Let's just keep it to myofascial pain syndrome. Simple. People have myofascial trigger points, or just TPs for short. What are they? There's those irritable areas that you poke on somebody, oh, they jump, they twitch, they hurt. They're sore spots. Usually they don't even know they were sore until you poked at them. Patients will say, oh, you did that. No, I didn't hear. You poke yourself. You see, you were sore there too. So Dr. Travell defined this as a hyperirritable spot, usually located within a taut band of skeletal muscle. You know when you roll your fingers across a patient's muscle, you could pretty much play guitar on that thing? That's called a taut band. It's a tight string in the muscle. And it's painful when you press on it, painful on compression, and it can refer pain to very specific areas within the fascia, not necessarily within the same dermatome. So this term's been around since 1942, trigger point. Have you ever seen a trigger point? Who's seen one? Oh, you're kidding me now. You've probably never seen one. You might have felt one. But now, actually, we can visualize trigger points using ultrasonic imaging. High-resolution ultrasound can actually, using the ultrasound transducer over the tissue, you can see differences in collagen density related to trigger points. And they look like what they feel like. They look like little nodules, and they're dense and hard. And you can see them on ultrasound. What's even more fun is you can actually see them change with the manual therapy that you do. So here's this study here, where they had 9 subjects who had trigger points and taut bands in their upper trapezius, the usual spot up here. And they found that these trigger points show up as a hypoechoic region of stiff nodules with reduced vibration amplitude and, interesting, high resistance to vascular flow. So again, poor blood flow. What do you get when you don't have blood flow and oxygen? Pain. Body knows. So trigger points seen on ultrasonic imaging. When we do myofascial release techniques, something as simple as skin rolling and pressing, Pohl did a study using ultrasound in 10 cases and compared normal tissue areas to restricted tissue areas and found, oh, you know, no pre and post differences in normal unaffected areas. The tissue looked the same. But in areas that had abnormal collagen distribution and trigger points, it completely changed post-treatment. So you can see the changes right away. And if you're licensed to use diagnostic ultrasound equipment, this is a great resource for you. There's an example of some of the skin rolling used in the study. Okay, myofascial release changes collagen density and tissue tension in what we call trigger points. These trigger points are dermal densifications, okay, and they are reduced by skin rolling. So you might as well measure it if you have access to diagnostic ultrasound. What types of trigger points are they? All different types. Dr. Travell labeled them: active, latent, primary, associate. Oh, there's so many. I'm mostly interested in active and latent, but I'm just going to throw some of those diagnostic criteria for you here. An active trigger point, it's an irritable area in the muscle or its associated fascia, and it's symptomatic, meaning it hurts by itself. You don't have to push on it to make it hurt. The patient knows it's there. And it refers a pattern of pain specific to that muscle. So in her books on the trigger point manuals, or you could get trigger point charts online, it shows you the specific pain referral pattern for each trigger point. It's always tender. It prevents full lengthening, so you're saying it's going to limit the range of motion. It weakens the muscle. This is a big nasty, huh? And it refers pain on direct compression. You might even see a twitch response or jumping. You ever hit a trigger point patient jumps right out of their chair? Sometimes maybe the muscle just twitches a little. We would say a positive jump sign or positive twitch sign. What's the latent trigger point? A patient doesn't know it hurts. You start poking at them and all of a sudden, ow! They say, oh, you did that. No, I didn't. Push yourself. There it is. Okay? Focus of irritability in the muscle that is clinically quiet, quiescent with respect to spontaneous pain. But when you palpate it, oh, they know it's there. Latent trigger point. Primary trigger points typically are due to a strain. Okay? Associated trigger points, new and exciting trigger points start to pick up areas of tension related to that strained muscle. Satellite trigger points, again, focus of irritability in the muscle, but it's in the reference pain zone for the muscle that holds the trigger point. Same thing with secondary trigger points. Irritable areas in the muscle, but that's not the primary problem. It's compensation to the primary trigger point. How do you find the trigger point? We're going to palpate. Get your fingers, do the walking. And there's different types of palpation. Snapping palpation is when you have that muscle in neutral. Say you checked some of your wrist and finger extensors, and you roll your finger right across the fiber at a right angle to the fiber. Okay? Like you're plucking a guitar string. That's a snapping palpation. You'll often feel a snap or twitch of the guitar string, and it might be sore. Flat palpation is just the muscles relaxed and neutral. You just compress directly against the muscle fibers. There's no rubbing, there's no stroking. Pincher palpation is just what it says. You pinch. Pinch those muscles. Okay? So a group of muscle fibers may be taut, and you can identify trigger points using any of these types of palpation. And I have courses on different types of palpation as well as manual therapies, so feel free to look into those. For your documentation, subjective, of course, what the patient tells you. Insurance isn't going to pay you anything based on that, but you need to have it in your note. Objective, you want reliable, valid measurements. So you observe their posture. Oh, the patient had a forward head posture with the head tilted to the left. So you palpate it. Oh, what's tight there? The scalenes, the upper trapezius, the levator. Oh, there's a trigger point right there in the upper trapezius. Patient jumped, positive jump sign. Patient twitched, positive twitch sign. Goes in my note. How bad did it hurt? Pain scale, 8 out of 10. Preferred pain up into the eye. Put it in your note. Was it crunchy? Did it snap under your fingers? You could say positive fibrosis. So all easy to go in your note. Measure the range of motion. Okay? How is their flexion? How is their mobility? Are they weak in their muscle testing? What about their orthopedic neurologic testing? Functional testing. If it's a neck problem, maybe do a neck disability index questionnaire. So you get a score. What level of disability do they have? What level of limitation do they have because of this problem? And of course, you have your assessment, your diagnosis, your impression, your problem list, goals, and plan. Is it myofascial pain or fibromyalgia? Well, let's look at them. Myofascial pain syndrome is usually very consistent in its presentation. Fibromyalgia, one day that's more their back, another day it's more their neck, another day it's their big toe. It's always different. Okay? Myofascial pain syndrome has typically deficits in range of motion, texture and tone changes that we just talked about on palpation, asymmetrical posture, muscle weakness that's documentable, and reliable specific testing results that you don't typically see in people with fibromyalgia. You can measure objective functional deficits. Fibromyalgia changes all the time, not consistent, and you have a lot of those comorbid factors that you don't typically see with myofascial pain. That non-restorative sleep, the fatigue, the visceral problems, somatoemotional problems. So you want to differentiate between them. We have a little clinical case study of a patient. In this patient case study, fibromyalgia syndrome, chronic fatigue, myofascial pain syndrome. Gee, what does she have? 58-year-old female office manager was presenting with chronic generalized pain for 3 years. Her initial presentation was she fell down the stairs. Her x-ray was negative, but her tailbone hurts, her back hurts, pain's worse in the morning. She has trouble getting up, she just can't get out of bed, she doesn't sleep well, and she's always tired. She feels better after a warm-up or later in the day, and she gained about 35 pounds in the last 3 years. So she's got a lot of stress at work, a lot of stress with her family. She eats a very poor diet, lots of caffeinated sodas with artificial sweeteners. Eats very little vegetables because she says it gives her gas, and she has this IBS as well. And also very significant history of severe stress growing up relative to childhood abuse, several car accidents and other injuries growing up. And she's tried all kinds of pain medicines, non-steroidals, nothing's really helping. She goes to a chiropractor to get some temporary relief from some adjustments and vitamins she gets there. And she also has pelvic floor pain, urinary urgency, irritable bowel, soreness head to toe, and everything gets worse with physical activity or stress. Is that enough? That's enough. She doesn't exercise at all because she's afraid it'll hurt worse. The last physical therapist hurt her, so she's not going back there. They went too deep. She went for massage. They went too deep. She's not going back there. Medically, she's hypothyroid. She's taken Synthroid medication, which has helped a bit with the pain and fatigue, and she takes a Prevacid for her heartburn. She's been to all kinds of practitioners with no results. What do you see on her posture? Forward head, kyphosis, forward shoulders, increased lumbolidosis and Q angle, multiple palpable trigger points and taut bands, positive jump signs, her pain in the trigger points, 5 to 10 on a pain scale. And of course, she'd write all this down. Make a note of where her weakness is. You could do a manual muscle test. I also like to use a dynamometer. I have a handheld manual muscle tester so I can document. Also, I said, what can't you do? Oh, I can't even vacuum one room in the house. I can't even type, sitting at the computer for more than 10 minutes. I'm exhausted. So give me a time. How long do you last doing activity A, activity B, activity? Write it down. How about at work? Well, she can't chase criminals right now. She's doing a desk job. Okay, she's got to do light duty. So she's gone from being a police officer in the past to basically managing an office because she couldn't keep up with it. I can't even stand up for more than 3 minutes in one place. My back's killing me. I get a headache. How about walking? No, I can walk slow, but after 15 minutes, I'm really exhausted. And I also notice she's a chest breather. So what are my interventions? Breathing exercises, number one. Guided imagery and to use on a home program a couple times a day. Progressive relaxation with the breathing. I taught her something called positional release to release her own trigger points. Posture correction using pillows and lumbar rolls. Got her a home TENS unit and microcurrent to help her. Checked with her doc about some medications to get her over the hump while we get her exercising and back in shape. And I started with some gentle aerobic exercise, a few minutes on the bike, a few minutes on the treadmill, a few minutes on the arm ergometer. Rest in between. Longer exercise each visit, shorter rest until she could do at least a half hour, 45 minutes of activity. Now you're talking that's taken 4 to 6 weeks to accomplish that much. Lots of manual therapies, myofascial, cranial sacral, muscle energy, reduce the trigger point tension and pain in the muscles, and improve the circulation. I referred her also, got together, spoke with her chiropractor who also is a nutritionist, giving her nutritional counseling, as well as sending her for stress counseling, cognitive behavioral therapy. So I conferred with some of her other providers, okay, what kind of lifestyle changes. Maybe she needs to get a little more relaxation, less running around in her lifestyle, getting her that emotional, mental support, okay. Collaborate with her primary care about her pain meds and working with several different practitioners. And also she loved to do the pool, so she ended up going in for a warm water pool therapy program as well and learned some Tai Chi. So lots of interventions out there that we could do. This is just one example, and that lady went back to working full-time, happily. Does she still have a diagnosis of fibromyalgia? Yes. Can she do everything that she's chosen to do? Yes. So many people like this. So there's lots of rehab approaches for fibromyalgia and myofascial pain. Okay. Manual therapy is one of my favorites. Myofascial release for stretching the abnormal tension in the fascial system and the muscles. Ischemic compression for trigger points, positional release. I've listed them here, and we're going to go through a couple of them very briefly just to introduce. What is myofascial release or fascial mobilization? It's basically soft tissue stretching, but it's maintained that you're applying a controlled force to the tissues of the body in a very specific direction at a precise depth for the goal of restoring or enhancing mobility. It releases adhesions and scars, it releases the fibrosis, reduces the pain, and improves the circulation. Myofascial release has been shown to improve fibromyalgia symptoms. A randomized clinical trial of 74 patients either got myofascial release with massage or a fake treatment. What improved? Sleep quality, anxiety, life quality, pain, and depression in the massage myofascial group. It works. Okay, so get those hands in there. Ischemic compression, what is that? Sometimes we like to just get in there and push on that trigger point. Well, that's ischemic compression. We apply progressively stronger, painful pressure on a major point. Now, I don't like to apply it to the point of sharp pain on people with fibromyalgia, very light. It blanches the pressed tissues, and as you release the finger, new circulation comes in, bringing oxygen and blood flow to the area. That's one mechanism, increasing circulation. The other mechanism it works is the gate control theory. Pressure supersedes pain, stimulates the A fibers that carry pressure sensation in the nervous system, and then overrides the C fibers that carry pain. So gates the pain. Melzack and Wall's pain control theory. Ischemic compression has been shown to reduce trigger points. Here they did a randomized clinical trial of people who had latent trigger points, those hidden trigger points in their upper trapezius, the ones you probably have too. Why not try it on yourself right in your chair? Find a trigger point here in your upper trapezius. Oh, there's a sore spot. Okay. Put just enough pressure on that you can feel the discomfort but no sharp pain. Hold it, and they hold these things from anything from 15 to 90 seconds. And after you release, what does it feel like? Is it less painful? Now, some people actually get an elbow in there on those trigger points. Something to think about. I usually use thumbs, fingertips. Some people use tools. So gentle, please. Positional release or strain counterstrain. Trigger points can be reduced in general by realizing that the trigger point is an indicator of joint dysfunction. There's a problem of tension there. Now, muscles holding tension. How to reduce the tension? Well, if you're thinking the muscle spindles control the muscle spindles respond to stretch. We take all the stretch off the trigger point muscle by basically hyper-shortening it. As we hold the trigger point to erase the stimulation, erase the stimulus that the muscle spindle is responding to. I'm being stretched, I have to contract and protect myself. We erase that muscle spindle hypersensitivity by shortening the muscle up massively. So it's inhibiting the muscle that holds the trigger point, essentially normalizing the bias of the muscle spindle. Again, I have courses on these. There are lots of courses online as well as live. Do check them out. Fabulous, fabulous technique. In this picture, we're showing shortening up, elevating the levator scapula, upper trap, elevating the scapula passively, side bending the neck to that side, shortening up upper trapezius to counterstrain that muscle, to reduce the trigger point pain. In a study by Wang and Shar, did a randomized clinical trial of subjects that had hip muscle trigger points as well as weakness, and found that using the pain scale and a handheld dynamometer, manual muscle tester, pre and post intervention, they divided people into 3 groups. A group got strain counterstrain, just positioning. A group got exercise. Another group got strain counterstrain with exercise. Well, we did a positioning of holding the hip abductor muscles in a short position, abducted, for 90 seconds, twice a week for 2 weeks. Guess what? Found a significant increase in strength and reduction in pain in the group that had strain counterstrain and exercise, but interestingly, not in the exercise group, and is maintained 2 to 4 weeks post-intervention. Is a study I did, case report, adult male athlete who had painful trigger points at upper trapezius and the suboccipital muscle, superior oblique. Treated again twice a week for 2 weeks, 90-second hold, shortening those muscles in a strain counterstrain position. I measured the Nicholas handheld dynamometer, the pain scale, self-reported outcomes, as well as neck disability index at visit 2 and visit 4. And guess what we found? Significant improvements in pain, strength, and neck disability from only 4 sessions. That's huge. 4 sessions, notice 90 seconds apiece of holding that trigger point. Another technique that's very helpful for managing fibromyalgia is cranial sacral therapy. This is a very light touch therapy, and it's using gentle pressure to the neurofascial structures, particularly the dural membranes of the brain and spinal cord, accessed through the bones, cranial bones, and the spine. And we use this to identify abnormal mobility and motion restrictions and facilitate restoration of normal motion throughout the cranial sacral system. So it's a very high touch therapy, and although it's typically focused on the cranium and spine, it can be used on the entire body to reduce abnormal tension and pain as well as promote functional outcomes. So just showing a little technique here, which again, you might want to try right in your chair as you're sitting there. Keep yourself awake. This is called a TMJ decompression. How many people are tense, clenching the jaw? You know, they often call that jaw clenching at night bruxism, the constant clenching and chewing of the teeth. Place your fingers just very gently over just below, okay, your zygomatic arch, over the masseter muscle, so you're above the angle of the jaw. And with your mouth relaxed and head neutral, tip of the tongue should be behind the top two front teeth at the roof of the mouth. You're going to do a very gentle, inferiorly directed glide with using pressure as light as the weight of a nickel. That's in the words of Dr. John Upledger, who is a cranial osteopath. So very, very light pressure. Again, weight of a nickel is about 5 grams. That's how light. So just a little bit of an inferior directed glide to decompress the TMJ joint, to relax the clenching muscles of the masseter and temporalis and the membranes of the craniosacral system. We hold that for an average of about 90 seconds to 2 minutes and gently release. There's much more to it than that, but I'm just showing you a little introduction to how light the touch is. They did a randomized clinical trial on 92 patients with fibromyalgia, and they said, let's put them in groups of either a craniosacral therapy treatment group or a placebo group for 20 weeks. And they checked their heart rate variability, as looking at their heart rate and blood pressure measurements and relative to stress and tension levels, as well as their pain levels. What did they find? Significant improvement in pain in 13 out of 18 tender points, and also their clinical global impression of improvement was much better in the treatment group than the control group versus starting at the baseline. They did a follow-up 2 and 12 months later and found that there was still a significant difference in the treatment group pain compared to the control group pain. So we do see some nice studies being started on craniosacral therapy being helpful for fibromyalgia. How about craniosacral therapy affecting hand function and pain? There's a randomized clinical trial in 23 people who had chronic pain, tennis elbow, chronic lateral epicondylitis. They measured several variables: pain, grip strength, and functional abilities. So they did only 6 sessions of craniosacral therapy and measured both pre and post test as well as 6 months later. What they get? Significant improvement in grip strength, pain intensity, function, and limited activity due to pain in the treatment group. And guess what? 91% maintained their improved function and 73% remained pain-free for at least 6 months. That's pretty substantial for craniosacral therapy. Very light touch. Another type of therapy often combined with myofascial or craniosacral work is somato-emotional release, also known as myofascial unwinding. This is sometimes called SER. It's a gentle movement therapy that practitioners learn to sense changes in tension using special handling techniques and palpation technique that we can feel changes in myofascial tension as a patient moves. We follow that movement with the patient, supporting them 3-dimensionally as they move against gravity to release the tension held in their fascial structure. Now, many times that tension is stored in the fascial structures because of some old emotional issue or old trauma. And guess what? Emotions are actually stored in the connective tissue. Dr. Candace Pert, psychoneuroimmunologist, has proven this. You could look up Dr. Pert online. She's done many studies through the National Institute of Health. You can help reduce some of this muscle tension holding using the somato-emotional release, and as well, a person may also release some of the emotional tension that they've been holding. They might have even forgot they were holding that emotional tension, and often that comes up. So it's an active assistive movement therapy, and if there are significant emotional issues, again, we highly recommend that you work with a qualified psychotherapist or social worker or someone who is trained to help that patient in managing the emotional issues. Let's take a look at muscle energy and PNF, or proprioceptive neuromuscular facilitation. These techniques use reflexes to either inhibit abnormal muscle tension, or we can actually facilitate muscle activation in muscles that are weak. Here in this example, we're looking to inhibit the abnormal muscle tension that's typically seen in chronic pain, whether it's myofascial pain syndrome or fibromyalgia. Again, these are just very brief descriptions of these courses, and there are many seminars available within which you can learn these online. I have home studies of these programs, as well as many other companies have them as well as live. So muscle energy and PNF is basically a manual medicine treatment. This is a quote from Dr. Phil Greenman from his book, Principles of Manual Medicine. Manual medicine treatment using voluntary contraction of a patient's muscle in a precisely controlled direction at varying levels of intensity against a distinctly executed counterforce applied by the operator. I love his terminology because it's all about specificity and precision. These are active techniques using the intrinsic force of a client's muscles. We're going to use reflexes to trick the muscles into doing what we want them to do. Either relax if they're contracting too much, or contract if they're too inhibited, to improve mobility and function. There's an example of a randomized clinical trial looking at the effect of what we call integrated neuromuscular technique, which is combining muscle energy and that positional release or strain counterstrain with ischemic compression that we were just talking about. A randomized clinical trial in 60 people from 19 to 38 years of age with those upper trapezius trigger points, separated the people into two groups. One group just got muscle energy alone. The other group got muscle energy with the ischemic compression to the trigger point and strain counterstrain. What did they measure? Pain scale, neck disability index, good functional outcome questionnaire, and cervical lateral flexion at weeks 2 and 4 post-treatment. And they found a substantial improvement in pain, mobility, range of motion of course, and disability 2 to 4 weeks post-treatment, with a significantly greater improvement in the group that had the multi-components, all three: muscle energy, strain counterstrain, and ischemic compression. How about a great massage, right? Who's not ready for a great massage? So massage can be very helpful. It's defined as a scientific application of touch and pressure to the body tissues in the form of stroking, tapping, kneading, vibrating, holding, stretching, pushing, pulling, and pressure to improve circulation, relax muscle tension, ease pain, and promote tissue mobility and function. There's a mouthful from our Practice Act here in New York. So there's many systems of massage, and most of them are aiming to relax the muscles for feeling good and promote good circulation and mobility. So how about balance and agility training? What's often called neuromuscular re-education. Might that be helpful for myofascial pain and fibromyalgia? So neuromuscular re-ed, the techniques using the neuromotor reflexes to promote normalization of muscle tension, improving mobility, improving balance, stability, and coordination, improving strength and power, muscle recruitment patterns, and functional mobility. So there's all kinds of neuromuscular work that can be done, everything from biofeedback and motor learning, sensory integration, therapeutic activities. We'll take a look at some of those on your own as well. Visceral manipulation, anyone familiar with that? Some people call it abdominal massage, but visceral manipulation is a very specific modality. It's been well researched and taught by Dr. Jean-Pierre Barral, who's a PT osteopath from France. And it's basically a manual mobilization of the fascial structures related to the visceral organs, as well as all the neuromusculoskeletal components to which they attach. So contrary to how it sounds, like you're just manipulating the organs, it's actually a whole body phenomena. And we use both direct and indirect mobilization of the viscera to improve the quality of the motility and mobility of the organs, as well as their functions, and to improve circulation, ease pain, and reduce tension. Now, you might have heard some of the latest on the visceral nervous system. You always talk about the sympathetic nervous system, the parasympathetic nervous system, but there's also a very specific visceral nervous system that's now recognized as its own system that has effects throughout the entire body. So I highly recommend look into some visceral manipulation training. Couple studies, I just listed the studies here, some alternative approaches to things like chronic pelvic pain. Looking at Potts' article on biofeedback and progressive relaxation for management of chronic prostatitis, and Srinivasan's myofascial dysfunction associated with chronic pelvic floor team management strategies. Anderson's study is also very good. They looked at an intensive 6-day treatment protocol for people with chronic pelvic pain and prostatitis, using specifically myofascial release and a special type of breathing relaxation training called paradoxical breathing. Significant reduction in pelvic floor pain, spasm, and improvement in function after only 5 sessions. That's huge. Belinda Wern and Larry Wern are movement practitioners that have done quite a few well-published research studies on dyspareunia and dysmenorrhea in women, as well as for studies in women with endometriosis, also showing that using visceral manipulation, myofascial technique, and a combination of techniques that they now call the Wern technique actually helped women improve their conception rates. So people who had difficulty conceiving had higher rates of conceiving and pregnancies as a result of having this very high-touch manual therapy. Are modalities any good, or is that too old-fashioned? Physical agents, yes, they can be very helpful. I'll often train my patients in the use of hot and cold applications, how to use TENS or microcurrent units at home, try to, as much as possible, cut back on their need for medication. Surface EMG electromyograms, measuring the muscle activity. Galvanic skin resistance measures the electrical conductivity and sweat response in the skin. These are indicators of the stress response. You can show on EMG, are they holding muscle tension when they let it go? And patients can be trained with specific biofeedback therapy to actively notice when they're holding abnormal muscle tension and then engage their brain to focus on relaxing that muscle tension. Same with galvanic skin resistance. You can increase the energy flow through areas. It's even been shown through acupuncture points using some of these techniques. So it informs the patient of something they might not have noticed on themselves and then gives them feedback to start to recognize, how am I using my body? How am I holding my body? How can I control my body's responses by thinking about it actively? How about other interventions, lifestyle, movement education, ergonomics? Gee, if the person goes and keeps restraining themselves by engaging in activity in poor posture or using bad body mechanics, they need to learn ergonomics. How about for sports? How many runners have I seen, or people training? I get people who are training for special forces in the Army, people training for Marines, and they need to do some very, very high-level performance. What's happening? They might be running in bad footwear. They might be using a poor training style for their sport. So something as simple as sports retraining and reeducation to maximize the biomechanics so that they can optimize performance and avoid future injury, avoid strain. Very important. Even just recreational folks. One of the ladies I'm treating currently had fallen and broken her shoulder, and she was having myofascial pain throughout her neck, her back, her shoulder. Although the diagnosis was fractured humerus, she had problems from her neck all the way down her spine from falling on the ice. So now she wants to get back to golf. So what are we doing? We're focusing on, I told her, bring your club in. I'll show you how to stretch using the club. We'll work with some of your golf swing to maximize your swing and help to get that movement back between your shoulder and the rest of your body so you can enjoy your recreation. Very important. Don't allow people to be subject to repetitive strain by using poor body mechanics. That contributes to more myofascial pain syndrome in my patients. Ergonomics, positioning, when they're using their cell phone, when they're using their computer, when they're eating dinner, sports coaching and conditioning, of course. You know, I'm not a tennis player, but if I'm treating someone who's a tennis player with myofascial pain, I'll refer them to a coach to make sure, what is their racket like? How is it strung? What is the handle? What is their swing like? These are things they need to learn. And then, of course, those bad habits, smoking, drinking too much, recreational drug use, you know, too many cookies, whatever it is. They need to get some control of those bad habits. I use hypnosis to help people with that, but there's many, many ways to work with that to help them to assume a more healthy lifestyle. How about people who don't want to take care of themselves? I can't tell you how many folks I've treated with fibromyalgia in particular just gave up. They will not take care of themselves because they gave up. Nothing works, so why bother? So, you know, you have to deal with that. So lack of compliance. Teach them about, you know, different ways they can empower themselves, why they might want to adhere to their therapeutic regimens. How about litigation? I've had patients come up numerous times and tell me, well, until I can be on therapy at least 4 months, my lawyer said I'm not going to win this lawsuit because I have to prove that I'm really hurt. Or, you know, I can't really work on getting better because, you know, if I'm better, then I'm going to have to go back to work. And right now I have work on the side for cash and I'm making more money there, so why would I go back to work when I'm collecting a disability check? I mean, sometimes this is going on. There's secondary gain, there's litigation. Certainly not everyone is engaging in that activity, but I've heard of plenty of people who are. And unless they decide they are going to put their health first, there's no point in wasting time. I tell them, look, I can't take your money. If you're not going to follow the program, there isn't much I can do to help you. Okay? Wait till you're done with your lawyer, then come back. Or let me work with you, with your lawyer, and give you the documentation you need. You don't have to exaggerate. You don't have to fake your injury. I can see what's wrong with you. I can document that and support you. So it's important to, help manage these unresourceful attitudes as some people come in, giving up, staying in stressful situations. Find them resources. And then the business of making excuses not to change, that's out the door. No more excuses. We're moving forward. Hey, it's not easy. Secondary gain. Ask questions. Be respectful with the patient. Don't assume that just because they might have litigation that they're faking something. Most of the time they're not. Okay? What are they doing that might be contributing to the fact that they continue having pain? Maybe they didn't realize it, doing something silly, hurting themselves by doing a poor biomechanical motion over and over and restraining, and they had no idea. What about the subconscious tendency? Well, they're used to being this way. They're used to all the extra attention they're getting. They're used to, being able to complain because someone actually paid attention to them. Maybe that's hard to change. Maybe they have a subconscious secondary gain going on. They didn't even realize. I had a patient tell me that the only time her husband doesn't beat her is when she's sick. So what is she all the time? Sick all the time. How about resources for making sure you get out of that situation? And that wasn't something that she felt she could do because of fear. So be aware, I'm not a psychotherapist, but I can refer people to get help in those situations. And that's something that's our responsibility to do. A lot of subconscious stuff going on. Don't make judgments about the patient. You don't know where they've been, but you need to respect where they are and help them to get to a better place. Okay? What are they getting out of their pain? That sounds like a crazy question. I don't want pain. What good is this pain doing me? Well, pain is a big helper. It teaches us not to do certain things that cause more pain. So it's actually a very good thing to have. But when it becomes chronic and overused, then we're not responding appropriately to the pain. That's where we need to look at all of today's interventions. And I'll ask people, what are you getting out of the pain? Is there anything good about it at all? Or what are you losing because of the pain? What's bad about it? I'll actually ask patients, make a list. What's the pluses and minuses about this pain? Well, the plus is it's telling me not to go and do that silly action again that caused me more pain, so I learned not to bend the wrong way. That's a good thing. Or, gee, it taught me that I'm in a bad situation and I have to change my job because that job's not healthy for me. Okay, so pain is a good thing if we listen to it and follow through. If you just let it drone on and on, if it's continuing, you're not making a change. Pain is calling you to make a change. So you need to access resources for that patient so they could find out what kind of change it is they need to make. And then, of course, the bottom line I like to ask is, what can I learn from this problem? Okay, nobody likes having fibromyalgia. Nobody likes having myofascial pain. But gee, did you learn something from this? Well, I learned I really shouldn't be jogging in the street because I got hit by a van and broke my back. Well, gee, that might be a reason for your myofascial pain. But I learned from the pain I shouldn't be jogging in the street. I should jog at the track. And sometimes it's as silly as that. Sometimes it's much more involved. But avoid judgment, but ask questions. Let the patient come up with their own results. And then, of course, I've tried everything. Well, I've never seen you in my office before, so apparently you haven't tried everything. And that's something where they tried a few things, they failed, so it's like, I'm not going there. Okay, so sometimes they can't find their way out of a paper bag. They can't find their way out of their problems. They just give up. It's very common, especially with depression. So we need management, we need education for the patient, lots of compassion and encouragement, and then support that positive change. How about happy times? Laughter is great medicine, okay? Especially with fibromyalgia, especially when there's a depression component. Try some comedy. I tell people, what do you love to do? Oh, well, I used to love to play tennis, but now it hurts. Okay, do you like to watch a tennis match? I like to get together with friends and watch it. Okay, so do something fun. Go to a special place. Oh, I love to be in the woods, so go sit in the woods on the bench. You have trouble walking, sit on the bench, enjoy nature for a few minutes. Find a creative hobby. Maybe there's a hobby. Oh, I'm too busy to be bothered doing my stuff that I like to paint. Well, take out your paints, give yourself 15 minutes of painting. Something that you enjoy to pick up your mood, to decrease the depression, to decrease the pain. Change of perspective. Oh, I'm always stuck in the house. Well, get out in nature. Take a walk. Okay, can't get out in nature? Go on the internet and go look at nature on the internet. Do something that makes you feel good. Endorphins are produced by happy situations. Endorphins are natural painkillers. Okay? And encourage them. Don't count the days, make the days count. You need to look at the positive. Stop focusing on the negative. Focus on the positive. Norman Cousins, you probably recognize the name, popularized the whole aspect of laughter as good medicine. And they did studies comparing pain thresholds in a couple different experiments to determine the effect of laughter on pain thresholds in normal subjects. Guess what? It works. You feel better. First study, 40 subjects, sensitivity to pressure-induced pain. They squished them so hard till they hurt, and they measured with a dolorimeter before and after, listening to an audio tape of either relaxation induction, like a meditation, a dull, boring narrative story, or an audio on laughter. Guess what? Pain thresholds were higher after they heard the laughter audio and relaxation, but not the dull narrative. So don't bore anybody to death. You're not going to help their pain at all. So have a good laugh. Another study, 40 females with matching pressure pain thresholds was separated into 5 conditions. Listening to a boring narrative, an interesting narrative, one with laughter induced, performing a math task, well, that would give me pain, and a control group. Who had the highest pain thresholds? The people who were laughing, getting those endorphins. So get some relaxation and get some laughter and get out in nature, lower the pain. Complementary medicine, acupuncture, herbs, hypnosis, autogenic suggestion is all helpful. Something called emotional freedom technique, or EFT. You could research that online. It's a certain tapping type of technique that's been shown to be very promising in managing pain. And then, of course, there's all the energetic therapies, energetic healing, therapeutic touch. Therapeutic touch has been very well recognized online in hundreds of studies, also in hospitals around the world as being effective. Reiki. Don't just, put an eye on that and say, oh, I don't know about that. That's crazy. That's spiritual healing. Spiritual approaches help as well. So if these people have, a church, a synagogue, someplace they go, perhaps there's some good support for them there as well to help manage the pain. So hopefully you got some good ideas for managing pain. And if you look back at your list of thinking about those 3 patients you're reflecting on and what you did to control their pain, or what worked and what didn't work, look at that list now. What can you add to that list? How can you change your practice to be more effective in helping people to get past their pain and into a more fabulous lifestyle? Thank you so much for taking the time to view this program, and hopefully I'll see you at a future live event in the future. I'm Teresa Schmidt, and you have here my website, edgicize.com. Feel free to visit me sometime. Thank you.